自己，嘿。喂喂喂，有了有了，哎，没有了，喂喂，一二三，喂喂喂喂，一二三，一二三，一二三，喂喂喂喂喂喂喂喂喂喂，一二三，一喂，一二三，一二三，一号，喂喂，有啊，一二三。 喂喂喂喂喂喂喂喂，123，123，喂喂123，1应该是有吧？不是我这边看。喂喂喂喂喂喂， 都去有元泰嘛，它有带
123，123，那个会场那边有人吗？
喂，有听到吗？
有，那个会场那边我们可以来做那个声音跟视讯的测试。
哦，你们那边等一下哦，好。那个电流声是他们的吧？你这
电
边
流声哦。
你开太多是？好。
123，123，
有。
声音
有。
2、
3。
1、2、3、4、5、6、7、8、9、10。123，郑杰，
好。
你那边有我的声音吗？
有，比较小声。
比较小声哦。那再一次哦。1、2、
你加
3。
大有电流声。
对。我这边有加大会有电流声，是不是？
没有，我这边加上去会有电流声。
是你那边吗？
你帮我跟阿军说，他那边可以，我送出来的声音可以再送大一点吗？
好的，等一下，他听你，好。
阿军，你送出来部分那个音量可以再给我大一点吗？
现在推了，再推一下，这样够吗？
等一下，
稍等一下哦，你就推看看嘛。好，来123，123，这样可以吗？123，这样音量可以吗？会场，123，123，123，123。
可能你戴口罩的关系吧，声音比较小声。
戴口罩是不是？
对，声音
等我
比较小声。
因为我现在是用那个麦克风。123，123，123，123，123，这样子呢？
有。
没有，因为我现在是用麦克风啊，到时候他们那个耳麦的时候，声音会比较接近。
好，可以。
好，123，123。那我们这边的画面过去是卡巴，那边有收到画面吗？
有。
好。
对，可以。
好，那个会场这边我们视讯患者那个简报那边看得到吗？
有，可以，你走个几张看一下。
好。
好，我看一下动画。
123，123，123，这样是可以吗？
可以。
123，123，123，123，121，122，122，test 1 2，哈哈，123，123，123，123，123，123，1啊？为什么？哦，1、2、3、4、5、6、7、8、9、10、11、12、13、14、15、16、17、18。喂，那个会长那边有听到声音吗？
有，可以。
好。
可以。
刚刚的声音都清楚吗？时代都清楚吗？
你那个动画我再看一下。
动画部分是不是？
可是你试一下，看有没有声音。这样讲话可以？你说可以。可以。
动画的部分。
好 ，OK。
好，你再看一次哦，来，好，好，我们现在开始动了，那边 OK 吗
？OK，可以。
白色字有出现吗？刚刚
有。
好。那我们会场，我们这边的那个声音跟视讯测试 OK 了，我们现在稍等一下，我们才能进去把其他讯号都打开。
好，达文西的讯号嘛，对不对？还有摄影机。
那个现在才刚进手术室，手术室现在才可以进去，所以他们现在才进去开刀那个摄影机，现在还不能进去，稍等一下，所以我们现在还没有摄影机跟达文西的讯号。
好，收到。
来哥，我这边可以给你测一下1、2、3、4哈，我这边讲1，你那边2、3、4，我们就这样一起下去啊。来1，有人吗？有人吗？有人可以跟我测这个3、3、
4、
5、
6、
7、
8、
9，
10。
好 ，OK， 可以，应该是还 OK。
好。
我现在看你的声音，你听，如果听得到有。好，现在没有。哎，没有。哎啊，有。
来，声音测试，这样医生有听到吗？有听到 ，OK， 好，谢谢。请问主会场那边现在看到的画面是达芬奇跟那个手术室的画面吗？
对。
好。芬奇的画面进来了，请问那边有看到吗？
有。
好，主会场那边我跟你做一下画面确认。我现在先给单框的现场画面，现在是现场画面吗？
对，现场。
好，现在是简报画面吗？
对，简报。
好，那这是达芬奇的全画面是对的吗？
对。
好，那我现在改成大小框，现在是那个现场画面跟达芬奇的画面对吗？
对。
好，那是现场跟简报对吗？
对。
好，确认好，没事。那 OK，好，那我现在就先送着达芬奇的画面，谢谢。
好。
好，我找一下。
对这个，你再转你舒服的音量。
好。 长大会现场，请问有听到我的声音吗？
有，
有的，那麻烦大会帮我做2件事情。第一件事情的部分的话，那个主持人帮我改个名字好吗？
好，
然后第二件事情的部分的话是，我等一下这边跟你测试讯号都没有问题了，那我这边我会先静音，然后一直到8:40的时候，我这边再打开我这边的讯号，可以吗？
可以。
好的，那麻烦您先改名，然后我这边先关讯号了，麻烦大会了，谢谢。
好，OK。
开始吗？哦 ，OK。那我可以请他们那个。OK， welcome everybody join this international multidisciplinary meeting. I'm one of the moderators. I'm Yan Xian from National Chengkou University, Thailand, Taiwan, and my co-moderator is Professor
Yosuke Noe from Tokyo.
Today, the presenter, the operation was done by the Professor Wang and his team now in the operation room. So everybody can, if you have any question, please hand up and say loudly to let them know your opinion and your question, so we can then call Professor Wang to answer your question. So now we start the meeting.
First of all, Professor Shi, do you have any information about today's case? Yes. Oh, yeah. Okay.
Wang教授, Professor Wang, can you show your face?
Hi, morning.
Morning. Can everyone can everyone hear me?
Yes.
Yes, no problem.
Okay, thank you. So good morning, everyone. I just want to say a few words. It's my great pleasure and privilege to welcome all of you today to see the live surgical demonstration. So I want to take this time to sincerely thank all our distinguished international and of course local guests for taking the time to join us here today. And I would also like to extend a very warm welcome to some of the colleagues joining us from online around the world. So it's really our team's honor to have everyone here. Your participation today makes this event really meaningful to all of us. So before we start the surgery, I want to introduce some of my colleagues who will be supporting me during today's surgery. So first of all, I have Dr. Shiqing Chen, if you guys can just say hi, and Dr. Xuanyu Su and one of my fellow over there, Mandy Wang. They will be supporting me for the surgery today. And Dr. Su will take a brief presentation of today's case and also explain the rationale of our robotic trocar design. So I'll hand on to Dr. Su to present the case. Thank you.
Okay.
Okay, before Dr. Su introduce their procedure, I must briefly introduce Professor Wang. Actually, Professor Wang is graduate from Yi-Ming University, and he is the student of Professor Xi. Actually, their team is the best robotic in Taiwan. They perform more than 1,000 cases robot surgery with robotic people in Taiwan. Dr. Wang is also very famous about his surgery, especially in the pancreatic cancer. So today, we are lucky and very great, appreciate Professor Wang's team introduce their case. Professor Wang. Okay, keep going. Your one, Professor Su.
Okay, we can start the presentation.
Yeah, please.
我们可以介绍。
Okay. Can you hear me?
Yes.
Okay. Good morning, everyone. I'm Dr. Su. Let me briefly introduce the patient. Mr. Lee is a 61-year-old man who presents with obstructive jaundice for 1 month. On abdominal CT, we can see an abrupt narrowing of distal CBD. On MRCP, a lesion is noted in the pancreatic head, which shows low signal intensity on T1 weight imaging and high signal intensity on DWI. Based on the clinical presentation and image finding, we plan for robotic pancreaticoduodenectomy. Next, I will briefly introduce our port design principle for robotic pancreaticoduodenectomy. We first insert a trocar via umbilicus for laparoscopy inspection. The port placement is adjusted according to the patient's abdominal status. Arm 2 camera port is placed to the right of umbilicus. The other trocar arm 1, arm 3, and arm 4 are designed as shown. For the assistance ports, the A1 is placed through the umbilicus, and A2 is between camera and arm 1 trocar. The trocars are arranged in a gentle concave configuration. If the initial inspection reveals no unexpected finding, we extend the umbilical incision to approximately 3.5 centimeters and place a wound protector. This technique was inspired by Professor Inoue and has been incorporated into our routine procedure by Professor Wang since last April. With a wound protector, we can insert 2 trocars at the umbilicus. During the mesopancreas dissection, we temporarily shift arm 3 to umbilical wound using trocar in trocar or one of the umbilical trocars. At the point, the A1 can be placed through the arm 3 trocar and through the other trocar in the umbilical wound. Then we preset 2 Jackson Pratt joints before we start the operation. Let me also briefly describe the route of the 2 joints. D1 is placed below CJ, then above PJ, below PJ, and finally direct toward Morrison pouch. D2 is placed below CJ, then below PJ, above PJ, and finally directed toward IVC. This is our standard port and gen configuration for robotic pancreaticoduodenectomy. I hope you enjoy the surgery. Thank you.
Thank you so much.
So if there's any questions, I would like to sit on the console and start the surgery. We've already taken some of the time to finish the docking and did a little bit of the procedure. So can I proceed?
Wait a moment. Maybe some surgeons have question about it. Professor Yang, how about your procedure in your hospital?
Thank you for the wonderful introduction of the procedures. So every hospital has a different position and then procedure. However, in our hospital, we perform the laparoscopy dissection and anastomosis by robot. Basically, we can do the totally laparoscopic or totally robotic system according to the number of assistants and the severity of the obesity of the patient. So you said that you translocate the main trocar side according to your mesopancreatic dissection. What is the reason to change the working port according to the procedure?
Professor Chen, yes, do you mean during the mesopancreas dissection when we do the trocar exchange?
Yes.
Are you talking? So right now, if you see the arm 3 as the design axis, the SMV is maybe around here. We can see this is a gastrocolic trunk, so we know that SMV and SMA may be around here. So if we continue the entire procedure with the original design, where the robotic arm 3 is to the left side of the anterior accessory line, I don't like the axis. And so during the mesopancreas dissection, we always do a trocar in trocar method, where this arm will be now at the assistant side. This is a A1 trocar. we only do a trocar-in-trocar transition during the mesopancreas dissection because we think the axis is more parallel towards the SMV and SMA. But now we add the wound protector. So sometimes during this part of the procedure, you can either do a trocar-in-trocar, the 8mm trocar into the 12mm trocar port, or we can just add about 8mm trocar on the wound protector. So in that way, we have extra assistance. This part, when we do mesopancreas dissection, you will see how we change the arm 3.
Professor Wang, so in this case, today's case, you will perform the mesopancreas dissection in the final stage of the dissection procedure, right?
Yeah. But my habit is usually to try to examine the SMV at the lower border of the neck. And if possible, I want to also control the gastrocolic trunk. So, but today we are worried because of the time concerned. Usually my case takes longer time. So I was thinking that before you guys come, I may take out the stomach. But now everybody has arrived, so I will just do my usual habit of dissection around the SMV first. So can I continue while you guys talk? And I try my best to do the surgery in time.
Yeah, please go ahead.
So I can continue. Okay, thank
Please
thank
go on.
you.
I will try.
Okay.
Try our
And
best
yeah.
Okay.
I will probably sometimes ask my cameraman to switch off my voice. Just I don't want to interfere, but I can hear you guys talking, and if it's necessary for me to answer, I'll just open my mic again, if that's all right, because I don't want to interfere too much. Sometimes I talk a lot in the OR.
Okay.
Is that okay?
Yeah.
Okay, please go on.
Okay, thank you. 麦克风关。
Professor Inove, from the Professor Su's introduction, he used the umbilical pole. He says it's designed by you.
Yes.
Can you say
my pleasure. Yeah.
Why you accept such an umbilical have 2 holes?
Yeah. Using the multi-port system on the midline incision is very flexible and very convenient for us, and it is developed from our stomach surgeons in Japan. So we learned this method from gastric team. And then sometimes we use the midline incision for the robot, and sometimes for assistant, and sometimes for both. And we can also use it for specimen extractions. So from the first period, we open 3 or 4 centimeters midline incision and apply the multi-port system. Yeah.
So if you use the trocar-in-trocar system, I think the selection of the window protector with the trocar the ports, the trocar is important. What kind of the trocar do you use for the trocar-in-trocar?
Yeah, we can use many types of the system, and my favorite is an easy access system. Easy access is very simple, and we can penetrate many holes.
That is like a gel port?
Gel port.
It's like a kind of gel port, not gel, but it's a kind of gel port. And other option is a kind of a button-like port. It's more flexible. But it depends on the preference.
Professor Yang, how about in National Taiwan University?
So almost the same.
Great.
Professor Hinono, I know you use the robot for SMA approach recently. Did you change the position to pose?
Yes, I also learn from Innove. So I prefer changing a camera port, and we use easy access, and port, using port, Ajaxis.
Okay. Professor Nagakawa, any comments for this kind of switching the scope site? You sometimes use it.
So when we perform the SMA dissection at the right side of the SMA, so actually we insert the camera in the number two.
R2.
Yeah. So to adjust the line of the axis of the SMA. So actually I also prefer to use the harmonic scalpel. So the to align the axis of the SMA. So we insert using the umbilical port, and to adjust the SMA. So I just want to ask Professor Wang, so that when you perform the dissection at the right side of the SMA, so do you also change the camera port?
Yeah.
So right side.
Generally from the right side. Yeah.
Actually, I prefer to obtain the straightforward, not tangential, straightforward the view of the subject. So if we dissect on the right side of the SMA, SMV, I prefer to insert the trocar from right side. It will be the best exposure. And I have one question to Professor Yum. Every time I watched your video or your procedures, your surgical field view is very excellent, very good exposure. But maybe I think you don't use this kind of scope switching or scope transition. How do you make such a good view in laparoscopic surgery?
I don't use to change trocar position. I use the flexible scope.
Oh, that's
and during this SMA dissection, I placed patient is right side up.
Yeah.
So position change and flexible scope is very useful to show this good operative view.
Yeah.
During this SMA dissection.
Yes. Someday you taught me that retraction is crucial to make the best view. Yes, I think it's really unique in the laparoscopic surgery. It's more flexible about the patient positions or flexible scope. In robotic environment, it's sometimes difficult. Is there any comment about view angle or scope positions or trocar placement from audience? Oh, now the Professor Wang is using the bipolar dissection method. This is really popular in Japan.
Yeah.
And I want to ask you from international guests outside Japan, do you using this kind of bipolar dissection method? How about you in New York?
I do most of the case with rather thermal scissors, or I'll do it with the robotic vessel sealer. We are fortunate enough to have a DV5, and I think one of the things that, as my practice has changed, I use the curved vessel sealer.
New one?
A new one on the DV, which is only on the DV5. I wish it was on the XI. I could use it more often, but the size of the curved vessel sealer is much more similar to the Maryland ligature. So particularly for the SMA and the mesopancreatic dissection, you can get into the smaller places well, whereas I find with the robotic vessel sealer, it's a little too bulky to get in some of those places. So that's when I would switch to the thermal scissors and do my dissection with that. But now on the DV5, when I'm able to access the DV5, I do most of the case with the curved vessel sealer. I think it ends up being a very nice, very nice tool.
Yeah, I think so. I agree. Is there any comments from South Korea, Professor Jian? How about the instance of bipolar dissection in your country?
So to do the bipolar dissection, we need a different energy, the power. So I tried the bipolar dissection because our opposite team prefer to use this kind of the dissection. But when I applied that kind of the procedures, it takes a longer time. And so I basically use the harmonic scalpel for the dissection to enhance the dissection time. And then for the repeated surgeries, I prefer the harmonic scalpel mainly during the dissection.
Okay.
Professor, in a way, you described for us about you use the umbilical from the gastric cancer surgery first in Japan.
Umbilical?
Umbilical pole.
Yeah.
Yeah. I remember 10 years ago, I invited Hickey, Professor Hickey from Tokyo to Kaohsiung to present his laparoscopic procedure. He also very frequently use the bipolar procedure. So I have a question about, does your training young surgeon from the gastric cancer first, or training they perform pancreatic surgery directly?
Yes, it depends on each hospitals. But usually they start their robotic program from simple case, I mean the colorectal or the stomach surgery first. And this is a kind of social background because young trainees will receive their training in a municipal hospital outside the university in their fellowship or residency. During their first maybe 7 or 8 years, they will have a first chance to operate the robotic procedures. So I think it's too early for them to perform the difficult pancreas surgery.
Yes.
Yeah.
How about in Korea? The young surgeon use the robotic or from the other surgery first or from the pancreas directly? In our hospital in Taiwan, our young colleague, they use the learning the laparoscopic procedure from the gastric cancer first, then change to histopancreas, then low people procedure. All my young colleagues, I ask them to familiar with the procedure, to use the instrument. So how about in Korea?
So I think the education is very important, especially in the era of the MI surgery. The technically require the more the precise procedure.
Yeah.
So however, open surgery is still standard procedure, especially for the advanced cases. So stepwise, the education system is ideally better. However, in practice, it is impossible to do the stepwise procedure. So anyway, last year we launched the very special simulation center for the laparoscopic simulation and then robotic simulation, so that we can qualify their skill. So if they basically finished their curriculum to do the robotic surgery, so they can embark the surgery by themselves as an operator. So during the open surgery, we have the lots of the cases, so we don't worry about the learning from the open surgery. But anyway, for robotic surgery, it's impossible to apply the robot procedure without the simulation education before embarking the surgery. So currently we stressed on the education using simulation center and getting some qualified education finishing, so that they can embark in the robotic surgery, even in the robotic PD. During the 2-year fellow, most of our fellow do the robotic PD by themselves until the finishing of the finished fellow system in our hospital.
Okay, Professor Yi.
I'd like to ask our international guest speaker. For example, this case is very obviously very central obesity. So the degree of the surgical procedure is quite difficult, as you can see. Sometimes it's very easier to have bleeding. So in your hospital, what kind of energy you prefer to dealing deal with this kind of obese patients?
Do you think this patient is obese?
I was actually just about to comment on that. So this patient would be one of the skinnier patients that we would
in your
deal with.
yeah. I
In
agree
the
with
United
that.
States, even in New York, and I did my prior training in New York, in Texas, and they're even bigger there. But our average obesity, I'd say, on ours, and this was a challenge when we first started undertaking robotic cases, particularly when dealing with men as compared to women, as men, at least anecdotally, I find carry their obesity much more in the mesentery and centrally, whereas women it's more in the abdominal wall, and we can get away with a higher obesity. But for BMI, for example, we initially had a cutoff where we wouldn't do it over, say, a BMI of 35 or so when we did it, but that dramatically limited us because most of our patients, even those patients that have pancreas cancer and other types of cancers are quite high. Like our average BMI now in terms of doing this procedure is about that. It's upper 30s. And so, and we've done it, on patients with a BMI up to 60 even on some of these patients. So it becomes very challenging with exposure.
Really challenging.
Yeah, very challenging with exposure. And so not only for the dissection, but then even for, say, for example, it's a duodenal or an ampullary, then the duct's even softer and it's even more filled with fat, the pancreas, above those things. So to your point, though, the question is how do we maintain hemostasis in these situations? And that's part of the reason why is that we'll try to do most of the dissection with the robotic vessel sealer or the curved vessel sealer, something like that, because it's a little bit better at kind of maintaining that hemostasis. And not only that, as you get bigger, these bigger patients, not only are we worried about the bleeding, but also the chyle leaks and the lymph leaks afterwards. And those certainly have been a challenge at times in terms of how do we maintain that. And I find that the best device tends to be kind of the robotic vessel sealer or those types of devices, whereas, if you're trying to do, and I'd love to hear others' thoughts on this, and how do you deal with, or do you approach the lymphatic vessels differently with the bipolar technique here?
Yeah, Belly Tyree, you mentioned she applied a clip for the lymph duct from the lateral peritoneum, and maybe the commentators would have many opinions about how to prevent chyle leakage during the formal dissections of lymph nodes along the pancreas. Is there any comments from Professor Nagakawa? Do you think, what do you think about this dissection layer?
So actually, in our experience and also our pathological findings, so actually there is a lymphatic duct between the posterior side of the ancient process and the vena cava. So so we call this area fascia of the, I forgot exactly. Anyway, there is a fascia between the posterior side of the ancient process and the vena cava. So that fascia has a many lymphatic duct. So actually the lymphatic leakage, not chyle leak, lymphatic leakage often occurs around this area. So so to prevent the lymphatic leakage from this area, so we always, if the pancreatic cancer not involve the posterior side, we always preserve this fascia area. But if the pancreatic cancer involved this fascia area, we always completely removed it. And we also clipped the superior side and the inferior side of the fascia to prevent lymph leakage.
Yeah, I really agree with it. This is exactly the case today. Usually, we preserve this layer, this fascia, but as you can see, there is some indulation of the lateral peritoneum by the pancreatic cancer. So I believe she decided to resect the one more layer. And he very meticulously applied the clips. It's more than I do in my usual case. Yeah. Is there any comment from Professor Jiang?
Yes, this is very important discussion on the extent of the dissection. So I think that this is a distal CVD cancer. So retroperitoneal, the too much dissection is not helpful to increase the curative resection in this patient. So however, the mesenteric approach, as Dr. Wang said, is usually is not needed for the dissection of this patient to preserve the many of the soft tissue on the pancreas. To get the larger resection, the standard dissection is enough. So if you dissect too much, it is related with several complications and like including the colleague. So I want to ask about the Hewitt about the surgery on the obesity patient. How, because in Asia, usually the BMI over 30 is the very the obese patient. So how's about your experience on the open surgery and the robotic surgery for the obese patient? Some of the robotic surgeons said that the robot is better, especially for the obese patient. How's about your real feeling? Which procedure is much comfortable to the surgeon? And then recovery.
Yeah, I think certainly when it comes to recovery, your last point there, I find that the patients do a good amount better with robotic surgery in terms of the size of the incision, things like surgical site infection rates being a little bit lower, particularly for the bigger patients. We do, particularly with open, it's not necessarily that they may get infected, but we have a lot more like subcutaneous necrosis when we close in those midline incisions and things like that. And so it's a lot cleaner from a robotic standpoint as far as the wound healing process and early mobility. And so we tend to favor that. There's a big push in the United States too because of the insurance and everything like that to get patients out of the hospital quicker. So for example, for our Whipples, they try to get patients out of the hospital in under a week. Is kind of the goal, and we have an internal goal at our hospital of 5 days is kind of what we expect for our average length of stay. And so there is a big early emphasis on early mobility, moving around, and we find that's a little bit easier when it comes to robotics. Now, as far as obesity, doing patients open versus robotic, certainly earlier on, I think open is the way to go, because the biggest challenge again, it just kind of comes with experience, but is maintaining adequate exposure in an obese patient. And one of the big keys is an extensive Coker maneuver and mobilization of the colon. If you can really mobilize it all the way to the lateral wall and even down the ascending colon a little bit, that will really allow you to drop that mesocolon and really help your exposure for this here. I mean, this is excellent exposure here. So I think that's been done really, really expertly here. But in the obese patients, the colonic fat sits on top of all this. And so you really have to mobilize the colon to drop it down so your assistant can really pull the colon down. And then the way she's retracting, you grab the duo and really kind of lift it up, and then that really helps its exposure. Because this is always the most challenging part, particularly in an obese patient, is because all the fat will start to collapse down, and it's very difficult. We'll use other adjuncts like bringing in extra, say, Ratex and modalities like that to try to push down and almost pack away the way you would in an open case. It is certainly easier, I think, to maintain exposure in some of those situations earlier. And it was just something that we had to learn over time as far as maintaining exposure in an obese patient. But now that we've had sufficient experience, I do favor the robotic approach in obese patients because of the recovery and the early activity. So even though it's a little bit harder for me as a surgeon, I think at times, I think it's ultimately much better for an obese patient to undergo a robotic case than it is an open case.
Anyway,
I'd like to comment on
the very good mobilization of the pancreas head. Okay. Yep, please.
I'd like to comment on is energy device for the preventing is colic and is oozing from is lymphatic fat tissue. Actually, this most Korean surgeons do hybrid laparoscopic resection. During laparoscopic resection, we can use various kinds of energy device. I prefer this bipolar, is a ligature. I think ligature is the better to this sealing, for preventing this colic. So this during the local surgery, it takes time to change energy device. One is use monopolar, sometimes monopolar, and is harmonic. Actually, this bipolar, this ligature is, I think it is better. This to make a clean upper field, and is preventing the colic.
Yeah, to keep the operation field dry, yeah, the sealing device is more convenient. Is there any comment about this topic?
Yeah, so I wanted to say about the energy device. Actually, so recently, the DB5, we can use a new energy device, the cupped vessel sealant. That is really nice. So also the want to use it. But one of the problems is that it's really expensive, and it's really expensive. So actually, I also believe that the harmless cover is also needed to dissect precisely dissection to form the precise dissection. But if I use a harmonic, also the curved scissor, so the cost is much become the really higher. Yeah.
What do you think about sealing performance of a harmonic device for lymph duct? Is there any comment or experience?
So in my experience, the harmless cover also can seal well the lymph duct.
Okay.
If we when dissecting the lymph duct, so if we do not move the harmless cover during the cutting, so probably I believe that the lymph duct completely stopped it.
Okay.
But during the cutting the lymph duct, if we move the harmless cover, probably the lymph duct leakage often occur.
Not to tear the tissues. Okay.
So we used several kinds of energy device at the same time. So I used the harmonic scalpel for the fine dissection. However, for the coagulations, I used the ligature or another kind of double bipolar the seizures. So especially for the fine dissection, I think the harmonic scalpel 1000 HDI is the best instrument for the fine dissection with a very speedy dissection. However, for the ligation, the treating the lymphatic tissue, I think the ligation, the remaining side, using the clip is very important. If we use the double bipolar or the ligature, so temporarily it works. However, the 3 or 4 days later, many of the ligated lymphatics are open and they make a chyle leakage. So for the dissection of the large lymphatics, we must ligate the remaining side. That is very important.
So you prefer the permanent closure of the lymph duct? I agree with you. Any comment?
I totally agree with Professor John's comment. Particularly for this kind of obese patient, although this is an easy one for our Western surgeon. But to my experience, harmonic scalpel is not so reliable for hemostasis for this fat. It's a very, very bad experience using harmonic scalpel to dissect. So I believe that maybe hybrid surgery using laparoscope and we can using ligature to have dissect procedure, particularly for obese patient, maybe a good options. And for conventional whip operation, maybe harmonic scalpel, there is a disadvantage because the angle is always fixed. It's very hard to adjust your dissecting angle. It's a disadvantage of the harmonic scalpel.
I'd like to discuss this dissection plane at this area. Actually, the one is trying to remove lymph node. But I think that area, lymph node metastasis, is not common. I think it's a superior side is dissection. We can avoid the lymphatic leak. In this area, most common site is a colic.
Yeah, I think so. Yeah.
What is each surgeon's preferred, as I explained, at this time?
So if you want to prevent the chirotic, do you use after harmonic scaffold? Then Dr. Zhang, he proposed use the clip in the.
No, I'm talking about dissection plane.
Yeah.
I try to dissect this area close to this pancreas duodenum.
Yeah.
This dissection, I think, they're too deep. We don't remove I think we don't remove that nose. Yeah.
So in the beginning of the discussion, I already talked about the optimal extent is needed according to the tumor location and the severity. But I think the Shini Wang is the one to show the standard operation for the pancreatic cancer. This case is the CBD cancer, as you said.
Is this a CBD cancer?
We don't need to dissect this area too much. However, I think the Shini Wang just showed the procedure, the routine done in the veteran hospital for the pancreatic cancer. I think.
I agree. In our hospital, in pancreatic cancer, I always dissect more. Yeah.
And according to the finding, I think the Professor Wang is suspicious about this lymph node because it looks like a kind of a massive. So maybe she prevent to leave it. So I think this will be the not usual layer for biliary cancers. But if the tumors are located here in the pancreas or incinate,
sorry, can everyone hear me?
Yeah, we are now
Thank you.
discussing
I've been
about the
finding,
dissection layer.
Yes, and I've been listening. Thank you very much for all the experts' comments. But at the beginning of our presentation, actually we are suspecting the patient may be pancreatic cancer. Okay. Not necessarily CBD. We're still not very sure, but the tentative diagnosis we favor is pancreatic cancer. This is the reason why we are doing this dissection. And about the retro pancreatic dissection, Professor Inoue is really my good friend. He can read my mind. This is the reason why I actually go more deep, because when we were doing the Coker maneuver, you can actually see the tumor. I can see actually the tumor is a little bit exposing. Yes, this is the reason why I decided to take more. Otherwise, I usually don't take that much.
Right.
Yes.
Right decision.
And this is the lesion that we are suspecting, and the same goes to this node. This is also the reason why this is probably the middle chole artery.
Yeah.
So that's why I try to dissect off this lymph node.
Yeah.
And this is the entire SMV that we are exposing now. Yes.
Dr. Wang, can I ask you one question?
Yeah, sure.
About your device selection during the Coker maneuver, you used the monopolar scissors. Is there any
Today is very special. So I don't want to limit my instruments. And also,
So I
want to use all
instruments.
now, especially today. So, and also the reason why I started to use the curved scissor is also because this year we started to have the SP instruments. And we know SP don't have any harmonic scalpel that usually our team, initially when we started the robotic surgery, we rely a lot on. Blue lock, please. So that's why when I decided that, especially on maybe pancreatic cancer patients, that during my robotic XI, I would want to consider adding a monopolar scissor just so I can get more used to the monopolar scissors, maybe finding the advantage of how to use it. And especially if I see some of the tumor exposing. Sometimes I don't like harmonic scalpel that much anymore because it vibrates a lot of tissue, a lot of steam, and the camera easily get full.
Yeah.
So that's why today, when I do the cochlear maneuver now, I think monopolar scissor is a good tool.
Okay.
Yeah.
To prevent
And
mist. Yeah.
yes, also to avoid continue cleaning the camera. And sometimes I worry that if it's too close, anything that's being maybe disseminated out, or just my own feeling that
comment.
I don't like.
Very good.
Yeah, especially on cancers that I can already see some of the exposure. That's why. And also now the double bipolar technique, of course, I learned from all my Japanese friends, and can see today it's very fatty and a lot of easy bleeding. And so when I want to do very meticulous dissection, especially around the vessels, at the beginning it was a little bit difficult for me to find the SMV. So I changed my harmonic scalpel to bipolar. Yeah.
Great. Yeah, likewise, I have a similar opinion, because if we use the bipolar dissection, we can go close, right? If we use harmonic, sometimes we get far from the tissues to avoid the mist. So I think this is one advantage maybe. Yeah? Do you have any comments about my opinion?
Professor Wang, so thank you for your wonderful procedures. So I do not want to bother your operation, making the question. You must be concentrated on your procedure. So seeing your procedure, you use the harmonic scalpel and the monopolar scissors, and then bipolar dissector. So according to your step, so I think about what is your determinant to choose the energy device for the dissection, and which procedure do you prefer to use, what kind of the energy device? That is very crucial because you use the...
Okay, so okay, sorry, I can talk now?
Yeah, okay.
Okay, yeah, if the patient is maybe low malignant lesions, such as like easy cases like IPMN, there's no inflammation and the tissues are really very favorable to our dissection, then we can just continue the entire procedure with harmonic scalpel, like always. But now if it's like especially pancreatic cancer, when I do lymph node dissections, I now prefer the double bipolar. Yeah, monopolar scissor is the last one I add on. Yeah, the last one I add on is when I have really fibrotic tissue and I feel it's very difficult to sometimes go through. Then I add monopolar scissor. Today, like I said, because it's a live demonstration, so I decided to use all the tools I can.
Okay.
I hope I can answer you.
Professor Inoue,
Did I answer you guys?
The energy mode is very important for the use dissector, the bipolar dissector.
Yeah.
Seeing the procedure of the Cine Wang, there is no thermal, not so much thermal injury around the tissue. So the choice of the dissection mode and then energy power must be very important. How do you select the energy mode and the power?
Question to me. Yeah, thank you. A very important question. Of course, we can choose many options, and we can choose several generators. For example, the most simple is Da Vinci generator. And in the exercise system, usual exercise system, we can only use the soft coagulation. It is not at all sharp. So we need a very adequate and efficient counter-traction to cut some tissues. But it is the most bloodless. And another option is connecting the FT10 or fourth triad from Medtronic to the vision card of a DV exercise system. In this case, we can choose the macro mode, the sharpest, and the starter mode, the intermediate, and the soft coagulation mode. It depends on the dissection layer of the physique of the patient. And I prefer to use the standard mode. It is the most, intermediate. And how about your opinion from other commentators? Same.
Same. Professor Yang? Same.
Same. Okay. Is there any comments from Professor Nagakawa?
So actually, I always use FT10 and I set macro mode and set also the 60 watt.
60 watt.
Yeah,
Yes.
60 watt. Yes.
60. Yeah.
Probably that is a common.
Yeah,
right?
I think
common
so.
in Japan.
Yeah.
Right. Macro mode and the 60 watt is
Yes.
the most common.
But sometimes the macro mode is too sharp for me. So we should be very aware of the adequate dissection layers. If we go into the adequate layer, I mean, for example, the outermost layer outside the nerve plexus, there is no massive or no dangerous vasculatures. But if we go into the nerve plexus or go into the fat tissues, sometimes macro mode, we encounter some bleedings.
Yeah, probably the dissection cutting method is important. So if we cut loose connectage, probably it's okay. We can quickly cut it. But if they cut fat tissue, include some vessel, so we have to slowly grasp the tissue, and then after the corrugate this area, and then we bite again and cut it. So probably the cutting method is important to prevent bleeding from the cutting surface.
Thank you. So you apply energy after you grasp in such bloody tissues?
Yeah. First.
Okay.
And
First
then
bite.
after that, we release it, and then the grasp again, and they cut it.
Okay.
So to prevent bleeding, it's important.
Yeah, thank you. In this sequence, I think the Professor Wang is seeking the root of the SMA from light posterior approach, so-called light posterior approach. Is there any commentators who prefers this artery first approach from light posterior aspect? Maybe in Western groups, many surgeons use this approach. How about you?
Yes, so there has been, I know a number of surgeons are doing what they would even call like an uncinate lift technique, which would also be kind of similar to this SMA first approach from kind of the posterior aspect. For the way I do it and many at our center do it is we go through a different progression of steps. And so usually what I'll do, because this kind of goes back to the very beginning about camera placements and things like that, I start with the camera in our 3-port, and so I do most of the anterior dissection first. And so we have a pretty good idea now in terms of resectability, because I think the key to one of the big benefits of doing this approach is if you weren't sure if you were going to commit to the procedure because of SNA involvement or something like that, we're very fortunate at our center to have a number of physicians that, and pancreas surgeons that have experience that if we did have to rather take a piece of the SMA or something like that, we have that capability. So almost every single case that we go here, it's not a question of being able to get the tissue, being able to get the tumor out. So we commit pretty early to the procedure. Once we do the diagnostic laparoscopy, once we confirm there's no metastatic disease, the very first step that I do is once I get into the lesser sac is I actually transect the stomach. So I transect the stomach, push it away, and then after that, that's when I basically get on top of the pancreas. I'll rather go from above or below. I'll rather take the hepatic artery lymph node and then work my hepatic artery into the porta, or I'll go from below the pancreas, identify the SMV, start my tunnel, and then go above and do it. And so actually the pancreas is the second thing I transect, and then depending on the case in particular, as I sometimes will leave the CBD till the end to transect it, or I'll do it at that point too, and then I hop the camera over and do all of this dissection after that. So I kind of do it in a little bit of a different mode as being done here, but this is also, yeah, this is a very common way still in the United States to do it.
I think that this approach is a so-called artery-first approach, and in the invasive cases, invasive pancreas cancer cases or advanced cases, we want to judge the resectability first before we divide the critical organs. So how do you think about this, concept of artery-first approach? Do you apply it in pancreas cancer? For me, I always performed artery first for all pancreas cancer or other kind of malignancies. It's our routine, but it depends on each hospital and the groups.
We will do SMA resections, and that's part of what my talk is tomorrow and things like that. And so we will do these more advanced resections. So we basically prepare the patient for any number of procedures in terms of whatever's required to get the tissue out. If we're really worried about whether or not something will be able to be resected, it depends on really a distal target. So it depends on how low in the mesentery it would go. As in, is it by the ileal and the first jejunal branches? Is it by where the SMA itself differentiates into multiple different smaller organs? So that's the part we would do before. We do the inferior pancreatic portion, and as long as that portion is clear, then we can pretty much handle most of the other types of vessel involvement.
Thank you. Is there a small bleeding from here?
You don't know? Any idea?
Artery first approach is good. So in my opinion, it's a very safe procedure. I think so. But Maple PD trial showed unfortunately the survival is not different between the artery first approach, mesenteric approach, and conventional approach. However, Maple PD trial also showed that CTC number is decreased from start to dissection in mesenteric approach, the conventional approach. So it means isolated procedure, not touch of the tumor. So so
yes. You use SMA approach?
Yes.
Professor Chan? Yeah.
Basically, thinking about the tumor biology of the pancreatic cancer, it is a systemic disease. So regardless of the type of surgery, it does not matter to the increased survival. Just even if we use the artery first approach or the conventional surgery, if we get the artery resection, basically no survival difference. Already Maple study performed in Japan showed no difference between the surgery type. So I think the mesenteric approach, artery first approach, has some merit. However, when you decide the resection, because currently MRI, CT, the resolution, the slice is just 1 or 2 millimeter. So we can finally decide the whether to resection or not. For the pancreatic cancer is usually possible, seeing the CT or MRI precisely before the surgery. So I think if there is some invasion or adhesion to the SMA or hepatic artery, do you stop the operation? But I think if we decide the resection, I resect the artery, the vein, and then according to our previous decision before the surgery. So I think in spite of some theoretical merit of the mesenteric approach, I think currently the mesenteric approach does not increase the resectability decision during the operation, because we must resect the patient when we decide if there is no metastasis during the operation. So in spite of some theoretical merit, I think that the mesenteric approach routinely is not helpful to get the artery resection or not. Depends on the patient and the condition and the surgeon's preference, we can choose the standard operation or mesenteric approach.
Okay, Inoue?
Yeah.
How about your update?
Yes, I think I really agree with Professor Jha, because in the pancreas cancer cases, the patient selection is almost everything. So if we judge the patient doesn't have any distant metastasis, we can resect even the artery. So it depends on our policy. So in such a case, we don't use the robot. But even apparently resectable small tumors, but sometimes we encounter the intraoperative finding of a contraindication, some peritoneal metastasis, or in our country, we check the lavage cytology. If it is positive, we have to discontinue. And in my previous hospital, we checked also the frozen section of out-cable lymph nodes, and we have to wait 40 minutes before we decide to resect.
Waiting for 40
yes,
minutes?
we have to wait before cutting the critical organs, so our operation time is prolonged. But its positive rate is 10% in all the resectable pancreas cancers. So if after that kind of rigorous patient selection, we can resect almost anything. And the approach is depending on the local condition of the patient. It's my opinion.
Actually, in resectable primary cancer, generally, less than 10% case, you will find peritoneal seeding or liver metastasis when you open the abdomen.
To my opinion, SMA first procedure just good for surgeon's attitude to help determine the resectability and if or not to resect the portal vein altogether. But SMA first did not change the cancer biology. Because you dissect the right side of the SMA, you did not prevent the venous metastasis or nodal metastasis. So I think SMA first is just a perspective of surgeon's advantage, but not alter the cancer biology.
I think so, yeah. Maybe it doesn't change the survivor because the recurrence pattern of the pancreas cancer is mostly the distant. 70% of the recurrence pattern is a distant. It cannot be changed by the surgical approach. But another advantage I feel when I use artery first is the early shutdown of the arterial inflow into the pancreas head. And so during the resection procedure, we do not encounter any congestion of the specimen. It is a kind of another advantage in artery first approach, in my opinion. Do you have any opinion?
Yeah, actually, I agree with you. Actually, the artery first approach has some purpose. One is to confirm the resectability. So the other part is to achieve the artery resection. But I think that the most important thing is artery first approach is to confirm the position of the SMA before starting the SMA dissection. So so if we don't confirm the position, identify the SMA area, and if we start the dissection around the SMA, sometimes so SMA injury or IBD injury may occur. So probably one of the most important things is to confirm the SMA before dissecting the SMA. Dissection around the SMA is very really important. So that is one of the big purpose that we have to do the SMA approach.
Orientation.
In our hospital, we perform the SMA approach, but we try to not reset the SMA because if you reset the SMA, even after you reconstruction, the post-operative mobility is high. So we try to use the divestment of the SMA. And
you mean you don't resect?
No. Initially, we try to reset SMA, but we found SMA resection, even you reconstruct with Gore-Tex, with the sufferance with graft, still high post-operative complication. Yeah. So now we use the divestment of the SMA
instead of resection.
Yeah.
I really agree with you. Yeah.
I think this advantage SMA approach should be differentiated according to approach type. Actually, this laparoscopic and robotic view from inferior side. I think at the time, this infracolic SMA approach is better. But this right side is sometimes difficult when it's a tumor very close to this SMV or SMA branch. At the time, is inferior view is better. The advantage is robotic or laparoscopic is different from open surgery.
That's the point.
Okay. Because everybody have a very fruitful discussion, we can take a rest for 15 minutes. Because the electron technology, they try to improve the resolution after the break. So we can take 15 minutes break. Okay?
Yeah.
Okay.
be a non-specific pancreas branch from the root of GDA. Oh, now she's ligating. What do you think about the purpose of this metal clip, Professor Shi? What do you think? What is the purpose of this metal clip on the strings?
You find the key point.
Oh, really? Oh.
Many years ago, you know, the most dangerous complication is bleeding because of leakage. And our drain will cross to the GDA. And before we know the intravascular cover stent intervention, we always send the patient back to the OR, and most of the patient died. And now, when there is a sentinel bleeding, we send the patient to the angio room.
IVR.
Yes,
okay.
yes. And the first time when I send the patient to the angio room, at that time, no bleeding can be found. But I put the clip, on the stump, GDA stump. And 1 week later, rebleeding happened again. So our radiation intervention radiologist told me it's better for you to mark the GDA every time. For the
it's for landmark.
Yes, landmark. I published that paper many years ago. You can check that. So it's our routine. The mark is not for the tie. It marks the stump. For cover stent placement. That's why we can reduce our mortality rate down to 1.5. Now our
very good number.
quick operation mortality rate is 1.5. Can shock be seen by radiography? Yes. Really? Even no bleeding. I ask them just to cover the GDA. Sometimes you cannot find the GDA stump, but you can find the clips.
I suppose the metallic clip is more obviously by radiography, right?
No, sometimes you cannot see the stump because no stump. We tied too close to the common hepatic artery. When
so you apply another metal clip here, right? From now.
Yes, that's a routine. That's a routine. You can see the next
additional
procedure.
clip.
After the tie, we apply additional hemlock, and then we push the two small metal clip down to the tie. It just cross to the stump. Just for marking, not for stop bleeding.
But I want to ask you, what is the two metal clips on the strings?
we are used to do that. Today's case is not so good because too fat. Actually, we prepare the other better patient. We prepare that with neoadjuvant chemotherapy for 3 months. But after 3 months, the tumor is still very close to the vessel. So we changed that case to this one. So, so we have no choice.
It often happens. It's kind of, demonstration operation. Do you use the robotic clips? You seldom use the robotic clips.
Seldom, nearly, because too expensive.
Yeah. So you do not open the package of robotic clips.
You mean robotic hemlock?
Yeah.
No.
No.
For
Okay.
people, we do not use that.
Okay.
But for SP, for SP cholecystectomy,
here.
we do that
Wow.
because it is not easy.
This is the answer.
This is the answer.
Yeah,
Right.
Great. Very good. Now I really understand. Okay.
Just
Right.
for marking. Just for marking.
And fix it. Yeah, very reasonable.
Especially for the patient with just the only sentinel bleeding. When you send the patient to the angio room, you cannot see the leak contrast.
So in such a case, you insert the stent.
Yes, we still insert
the
the
common
stent.
hepatic artery to prepare.
Yeah, just to cover the stump.
Great. Yeah, I agree.
Besides the clip marking the GTA stump, we also protect the stump with baseball ligament, round ligament, to wrap this area. I think this technique maybe most of the pancreas surgeon will do that. Is that right?
Yeah.
How about the pseudo-bleeding rate?
Our bleeding rate is between 4 and 8%. Bleeding rate.
Mostly in POPF case.
Nearly. Sometimes we do not know why, but nearly all of the bleeding related to the POPF. Between 4 and 8. Really? So our intervention radiologist is very important for us. They save many patients. Yeah.
How about the instance of postoperative PPH in SNUH? Less than 1%?
It's very
It's
low.
the lowest in the world, in my opinion.
PPH. I think usually the intimal area of the vessel is very bad. I only widened the vessel using the suture, not the clip.
A surgical clip. So the only the use the surgical clip is very useful to prevent any hemorrhage and the site of the stump of the GDA.
Not to injure or tear the intima.
That's right.
Yeah,
So the
belly
also,
parallel closure.
Yeah, yeah.
Not,
So
not squeezing.
Yeah. Optimally choose the size of the plastic clip is very important. So in case of the large, the GDA, we use a larger. The clip. However, in case of the small vessel, we use the optimal size of the clip. So we would not like to make any injury to the vessel during the dissection and the ligation.
You prefer the hemorrhoid?
Hemorrhoid clip.
Okay.
Yeah.
Before 2014, in our hospital, the children rate is 2.5%. But in recent 10 years, less than 1%.
1%.
Less than 1%.
Very low.
How about recent incidents at our hospital, 许多 N 女人? I remember less than 1%.
I believe it's
Less
it's
than 1%.
between 1 to 2%.
Very, very low.
I also use the creep. After ligation, use the creep, hemorrhoid creep. Yeah.
Another surgeons prefer to use the ligation or I think
Suture ligation and use the creep to hold the, yeah.
the instance of the origin higher by the majority very bad.
Okay.
Ours is,
Any
we do,
comments?
yeah, so I take it a little bit differently. If I do ever need to suspend anything, I use a vessel loop like that, but I don't like, because we used to clip it and tie it, and I felt sometimes pulling on the suture can loosen it even just a little bit, and so our common practice now is actually we use a stapling device. So we use a robotic stapler and then clip it right on the end of that. And if we do need to suspend anything, we'll get around it and use a vessel loop. I try not at all. Once I clip and come across the GDA, I don't touch it again. I try to not the whole case, just to kind of leave it alone. And then I agree, I do wrap it with the falciform at the very, very end. So in fact, sometimes I use the falciform to suspend the liver. So I'll take the falciform down at the beginning of the case and then use an endo loop and pull it up to the roof. And then that will help kind of expose our porta sometimes too. Now, again, sometimes our livers are a little fattier and it doesn't work, but that's kind of the standard approach for us.
Yeah. Anyway, you don't ligate in the tie.
I do not tie. No. I did before, and I felt that whenever we would do that, and then if I lift it up with the tie, it even loosened it. Just, not a lot, but it just enough. And so I felt uncomfortable with that. So I'll dissect around it. We'll do a robotic robotic stapler or a bedside stapler, either one, and then just a vascular load on that, and then we'll put a clip right where the first row of stapler is on the GDA stump, and have that.
Yeah, makes sense. Yeah, and please.
Actually, this GDA stump length also important, I think. There's the United States surgeon, some surgeons is preserve long segment is GDA. Therefore, there's just in case post bleeding for embolization into the stump. But I think it is not safe because it's a long stump is the end of the stump. There is turbulent flow, so it can. I think this increase the risk of shoulder aneurysm. But too much dissection of the proximal part also not good. So what is the ideal GDA stump length? We need to discover that.
Yes, it's a great point. Our standard length is a goal of about 1 centimeter. That's 1 centimeter of length is about kind of what we try to get. It doesn't always happen. Obviously, it depends on where the tumor is and many of those characteristics. But we do try to have a little bit. To your point, it kind of depends. If we're really going to get a a full clean dissection around the hepatic artery, then of course, then we have to do that. But otherwise, if the tumor's not up there, we don't get a full periadventitial hepatic artery dissection, and therefore we'd also stay away a little bit from that GDA stump takeoff. But you're right. Our standard is to use, like, if we do have a PPH from there, pseudoaneurysm, then we will try to coil it as our first choice. The stents can be very helpful in those situations, but whenever the hepatic artery is less than 4 millimeters, the stent occlusion rate goes up much higher. So we do tend to favor wanting to use embolization, and it does help if there's a little bit of a stump there.
Because now there are more than 100 international attendees discussion. So can you propose your hand and speak your question loudly
online
for international attendee heard your question?
Yeah, online question is always welcome. And yes, regarding the length of the GDA stump, in my opinion, it depends on the tumor location. So usually there is no invasion around the GDA stump. 1 centimeter is my the average, and I don't like unnecessarily long length of a GDA stump, because to make the longer neck we have to dissect more. Yes, and as for ligation of the GDA in robotic surgery, to adjust the optimal tension or optimal strength of the tying is very difficult even for me. So sometimes it's too loose, as you mentioned, and sometimes it's too strength to break the intima. So in this critical stump, I don't use the ligation.
We recently have one case because the CTA stump is too short, only 1 millimeter. After we shoot to ligation, it caused the compression to the root of the common hepatic artery. So finally, we try several times about. Finally, we dissect the suture area and they contract by the venous graft. So if we take the stump of the CTA is 2 times too short, because most of the pancreatic cancer patient, the age is old, and their vasculature is not good, not healthy. So sometimes we will compromise to the common hepatic artery profile. So
by robot, you do it?
The case we use by open.
Okay.
Yeah. So finally we use the graft replacement by
makes sense.
We call it artery. We call it vein.
And
so, as you said, in cases for the older age patient, many of patient arteriosclerosis around the GDA. In case of the severe arteriosclerosis, I don't know which method is safer than the conventional the ligation using the hemorrhag clips, because the hemorrhag is very useful for the most of the patient. But in case of arteriosclerosis, the severe calcification cases make injuries there. So I don't know which method is the best. Could you share your experience on the case?
In a severe atherosclerotic patient, do you have any experience?
It's when I have experience is the artery fracture. There's after the application, the clip, metallic clip is not good. There's this kind of the hemorrhag clip is much better, and I think I don't know this advantage of a stapler in the case. I know experience. How about this United States?
Yeah, most of the staplers we use too, and I would stress this particularly on the artery, we use a 3-row stapler. So it'll have 3 rows on that, as opposed to any of the veins. I'm very comfortable taking a 2-row stapler, but a 3-row stapler is what I standard to do now. On the GDA, even if it's really bad atherosclerosis, the stapler can handle that. The problem where I run into when I staple an artery is if it's the splenic artery on a distal pancreatectomy, that calcification can become a big problem if you're stapling across it, certainly. But for the GDA, I agree with you. The locking clips are much, much preferred. And then as far as the stapler, I haven't had any issues with the stapler being able to handle that vessel.
What about your opinion?
Actually, I also focus on the nerve tissue around the GDA. So the to encircle the GDA. So actually in my procedure I peeled off the nerve tissue around the SMA, and I also tried to expose the aventure of the artery. So if we do that, so that we can completely encircle it, and we can obtain the length between the root of the GDA and the peripheral side. So when you insert the stapler, probably we need to expose the GDA widely, and there also the branch of the artery from the GDA. So how do you do that?
So the biggest issue, particularly when you mention getting more length on the GDA, is the posterior branch that'll come off. And it's a small one, but it can certainly bleed. And so that ends up being always the challenging part. So depending on how far distal that is, if it's greater than 1 centimeter, it becomes much easier. If it's right around 1 centimeter or even a little bit shorter in terms of that posterior branch takeoff, it becomes a lot more difficult. And so then I'll take that first, and then I'll go down a little bit more on the GDA and come across. Now, that leaves a second opportunity to bleed, so I'd much prefer not to do that if I can. And then as far as the staplers use, what is helpful is actually many of these staplers will have a curved tip on the end, so you can get it underneath and curve it up, and then you can much more easily get around it. But yes, you do have to do a wider dissection, particularly for the 3-row stapler, because you need greater width above and below to get the stapler to fit. That's correct, yeah.
Yeah, in my opinion, another advantage of stapling is a closure of the distal stump. At the same time, you can scroll. Sometimes the distal stump clip comes off, and some back for breathing is very troublesome for me. Yeah.
Basically, I prefer to use the humeral clip, but sometimes I use the vascular GIA, especially those who had a very short stump. And the branching to the pancreaticoduodenal artery is the early branching cases. Using the endo-GIA is very useful to don't need to dissect to the lower side. So one time you can ligate transected that kind of the early branching GDA the cases. The cases especially very useful.
So in the case of a belly short neck of the GDA, you prefer the two rows of SDR, small diameter reload stapler, not 3-row.
I 100% use the 3-row.
3-row, okay. Now the Professor one is dissecting the suprapancreatic and the hilar lymph nodes en bloc. Professor Naka, what do you think about the dissection layer in this case?
Actually, this area is a really complex area. So because there are many nerve tissue, so one of the tissue is covered around the common hepatic artery. The other nerve tissue derived from the right celiac ganglion. So both of the nerve tissue is completely connected. So to isolate these each nerve tissue is a little bit difficult. So other nerve tissue that's derived from the right celiac ganglion contain the number 8P lymph node. So to dissect the number 8P lymph node, so that the posterior side of the nerve tissue need to be dissected. So probably this patient, so probably the aventure of the posterior CHA, common hepatic artery is exposed. So probably the nerve tissue covered around the common hepatic artery is probably it's a little bit peeled off. So probably it's a little difficult to isolate between the nerve tissue around the common hepatic artery, also the another nerve tissue that's derived of the right celiac ganglion.
In my opinion or impression, the Dr. Wang is now dissecting also the nerve plexus around the CHA, mostly behind the CHA, because the adventitia is exposed. Is this your common procedure, Professor Shi?
Our routine procedure, especially for the pancreas cancer, we always skeletonize the common hepatic artery and portal vein around that area.
So in other malignancies like pancreatic cancer, you do not dissect in this layer?
Not so much. Not so much. For the no malignancy or maybe epilobata, we just also dissect that way, but not skeletonize.
You do not skeletonize.
Yes.
Okay. Now she clips the upper end of lymph node 12A.
Yes.
I mean, the one of the hilar lymph nodes.
And now in our series, the most common complication is kylic. I think maybe related to the radicality.
Yeah. Every time I'm so impressed about the efficiency of assistant scripts. So I always educate my fellows to clip like TBGH group. Yeah. They always anticipate the next actions and hold the clips and just immediately after her indication they proceed. It's very efficient.
And they are all attendant.
It's a special setting.
Yeah. We have a six surgeon, pancreatic surgeon, and now it's a special case for our in our daily practice. It is always the trip resistant and maybe two or three round, not fixed one. This operation is an attending.
Okay.
Yeah.
I hear. Yes, I agree. I hear the Dr. Chen. Dr. Chen is the today's assistant.
Yes.
I hear that he is very good at not only the robotic, but also he performs very good laparoscopic procedures.
Yeah.
That is why, it's very comfortable procedure. It looks like I'm very jealous of it.
We help each other, especially for the difficult case.
Yeah. So in a usual case, your resident or fellow serves as a patient site assistant.
Yes.
Yeah. I was very impressed by your participation as an assistant. In many years ago, I visited your OR. You were so, active as an assistant to assist.
Sometimes I'm the
very difficult case. Assistant. Yeah, and a PVR case. Many cribs. Very sure. Cardiac. How about the reduction rate of cardiac after your implementation of this kind of cripping?
The cardiac is still very high. Usually
Still high.
Between 10 and 20. Very high, very high.
10 and 20.
And so for that, if there is no pancreatic, we still keep the trend until patient resume the regular diet and try to see if there is any cardiac issue. If there is cardiac issue, we just keep the trend.
Okay.
So the trend usually is removed very late. We are very conservative to remove the drain.
I think this is a very important topic recently. So I want to ask the commentators, how do you treat the postoperative Kai leak? As the professor she mentioned, he keeps the draining. But how about dietary modification?
For me, once there is a Kai leakage, I usually ask patient to have the fat-free diet for about one week, and then try to challenge with a regular diet. If there is still Kai leak, there are two ways. One is total parenteral nutrition, or ask a patient try to learn how to care the drain, and let the patient go home and prepare the fat-free diet at home.
So patient go home with their drains.
Yeah.
So what is the criteria for drain removal of a Kai leakage patient?
Until no Kai.
Okay, it takes a long time. Okay.
So it takes a long time.
Okay.
For my patient, the longest one is 8 months. 8 months. Just keep that. If they don't complain, just keep that.
Okay.
That is more safe. But a little bit uncomfortable.
What is the criteria? Is Kai leak volume when you decide to this change of diet, fat-free diet? What is the criteria?
No color change. One criteria is
starting the fat-free diet. How many?
When patient come back to my outpatient clinic, I ask them try to challenge the Kai leakage with fatty meal, and then if there is no color change, I can remove it, no matter what the volume. The other one is if there is Kai leakage, but maybe less than 10 millimeter, I can remove that. I just want to, if there is Kai leakage, it is localized.
In my experience, is the Kai leak is almost 1 liter. At the time, I do this diet change, but it's 500 to 600. There's no problem. I did clamp the JP, and then there's no problem. I remove. But most patients is no problem.
Yeah.
Even kyositis, even no kyositis.
So you don't administer the fat-free diet in such?
No, rarely. It's, when its drain is almost 1 liter. At the time I do, but 500, 600.
If there is no infection, no POPS, it's okay.
Usually there is no infection with the Kai leak. Usually.
Is there any comment from other group?
So according to our experience, the primary same to the Professor Scher's idea. So we control the diet, fat-free diet, and then if the drain reduced less than the 500, we remove the drain in spite of some chyle. But some patient they readmit due to the ascites, ascites. So sometimes it is very it can make a delay of the other treatment like as a chemotherapy. So recently we prefer to use the initially diet control. If the prolonged over the 2 or 3 weeks, we perform the radiation intervention, the sclerotherapy to the lymphatics. And not 100%, but the 60 or 70%, we can perform the sclerotherapy of the lymphatics. They markedly reduce the ascites, and then we remove the drain. That is very useful tip.
Yeah, I agree with you. But you mentioned it's a leakage from the outer cable area. That's for femoral lymph duct. We can approach to the outer cable area. But how we can approach to the peri-SMA lymph duct?
So there is the route to introduce the sclerotherapy. So our intervention radiologists perform the direct sclerotherapy sometimes, and the insert of the fine needle to the area of the pancreatic area. Sometimes they use the antegrade method from the femoral area to the site of the cardiac. It depends on the size and then location, they choose the different pathway. But anyway, that is very laborious and tedious procedures. Experienced radiologist is very important to do that kind of intervention.
I'd like to discuss about the sequence of this operative procedure. Now, this actually the Professor Wang tried to divide the bile duct at this time.
Yeah.
But this, for me, I resect pancreas first, and then is SMA and dissection, and the last part may be the bile duct resection. But it can increase the wider operative field. Is what is
I agree. I agree.
Actually, when I do the laparoscopic approach, so that we cut the pancreas first, and then go to the CBD. But when they do the robot, so I same as Professor Man's procedure. So when after the dissecting around the hepatoduodenal ligament, and then we cut the pancreas duct because we can obtain a good surgical field under the robotic surgery.
In extensive biliary cancers, distal biliary cancers, which has some finding of proximal extension, I prefer to preserve the bile duct at the last of the resection. But usually, we dissect the common bile duct and cut it, and sometimes we cut the pancreas first. It depends on the situations. Yeah.
About the chylous leakage in our hospital, even in open surgery, because we use the extensive method pancreas dissection. So almost all cases will develop the chylous leakage 7 days later after operation. And if you test the TG level in the chylous almost low, but it turns chylous whitish. So if the amount was less than 200 milliliter, I will let patient discharge with the drainage, and then remove the drainage 2 weeks later. So almost all cases can be removed the drain within 1 month. But if you perform the total pancreaticoduodenectomy case, you must be careful. In those cases, they will develop chylous peritoneum longer. So at that case, I will use the total parenteral nutrition for the case. But otherwise, I will ask patient to intake food as usual. Don't need to take the low-fat diet.
Yes, I agree. Not only for chylous leakage control, but also for blood sugar control. I prefer to administer the TPN in all total pancreatic patient. How about your opinion? You applied the central venous catheter in all cases for TP. You do. You don't do it. How about you? You have Meg?
So you're saying in the setting of a total pancreatic, or anytime you do total pancreatic nutrition TPN?
Yes.
Yeah. So in totals, I mean, it kind of depends on us, but yes, if they do get a leak, we have we don't hesitate to do TPN. That we use a PICC line through the arm to do that, and they can go home with that and care for that that way. Yeah, but we don't hesitate to do it. But a lot of it comes down to the amount of output, like how much is it putting out, for these patients. But it does, it does become a little bit easier to regulate their other, nutritional needs from TPN that way. Yeah.
And as for the instance of chylous leakage, we have had a study, retrospective study of chylous leakage after bipolar dissection, and surprisingly, the incidence of the chylous leakage in robotic surgery is very high, more than 20% in our almost 200 cases in our series. But there is no clinically relevant delays of discharge, or no clinical relevant elevation of Cravian D3 or more complications. And we compared the robotic groups and open groups, and we found the most, impactful factors for chyle leakage was the timing of diet. In open cases, our conventional open cases, our patient begin to start eating maybe 5 or 6 days. It's very, compared to United States, it's very, very slow. And in robotic surgery, the patient recovers faster and they start to eat 3 days. So maybe this is because of a detection of a chyle leakage in our slits. Because in open surgery, the patient eats after the removal of their drains. But the robotic groups eat during their draining. So we can find the change of the drain and we can notice.
How do you think about this idea?
Yeah, I think it's a great point. We on most patients, when we're doing like enhanced recovery, obviously if we're doing a Whipple on somebody who's 80 years old, it's different. We don't, we take our time. But for example, our standard post-op pathway for a Whipple patient, robotic Whipple patient would be, we do one drain in the abdomen. They don't get a NG tube at the end of the case. So it comes out at the end of the case. And then we start clear liquid diet on post-op day 1.
Wow.
And then if they're doing okay, then we do full liquid diet on day 2. And then that's when we really look at the drains. Because to your point, I think it's important, not a lot of great evidence for this in terms of what diet and how to advance it. But we do, before we pull the drains, we have the patients on some sort of a fatty type diet, at least like to your point, to pick it up. Because I do think that's very true. It's maybe not the rate isn't that much different, but our sensitivity or our threshold of picking it up now is much, much higher. But yeah, so we tend to move people that are appropriate along a little bit faster.
What is the proportion of patient who discharged after the PD with the drain?
So our rate's about, we're actually collecting all of our data now on that, and it ends up being not as high as I initially thought, but it's more so for leaks that, pancreatic leaks that are asymptomatic, but we tend to be a little more conservative with leaving the drain in on those patients. And I'd say our drain going home rate's about 15% maybe?
15%.
Yeah, somewhere around there.
It's a
So,
reasonable number.
yeah, it's about where it is. Yeah, so our average hospital stay is it's just under 5.5. So we have about 10% of patients that leave on day 4, post-op day 4, and then about 50% or so are around day 5. And then obviously, we have about a third of patients that are day 6, day 7, and then, if they have complications, obviously some of them stay longer than that. But robotic-wise, and that's pretty selected because we only do robotics on resectable or borderline resectable. The only locally advanced cases we've done have been distal pancreatectomy and celiac axis resections. So we do those robotically, but otherwise we don't do we haven't done a hepatic artery yet. We haven't done an SMA yet or anything like that robotically.
Okay, so your robotic patient only stay in hospital 5.5 days?
That's the median length of stay for our robotic cases. Yeah, there's a big push in the United States to get people out of the hospital quicker.
But more than 50% carry the drain.
And do they go back to their own home? Do they go back to directly to their own home?
That's a good question. Most do go home, but we do have a number of patients that will go to a rehab or a short-term, what we call a SNF facility taken care of. Yeah, so because we're finding higher and higher percent of patients that live alone. And so it's very difficult for them to go home. So even if they might be okay, we tend to try to send them to a center because that we know will decrease their readmission rate, which is another marker that obviously everyone we check on. It's one thing to get the patient out of the hospital, but if they're all coming back in a week or two, it doesn't. What are you doing? So that's not the right approach.
Yeah, it's sometimes depends on the social background. As you know, the Japanese society has the very surprising long period of hospitals. Every patient wants to stay longer and longer because the cost for hospitalization for one night is much cheaper than the hotels. So, you know, it's only the $30.
$30?
$30, $40.
No, even in
One
New York,
night.
where the hospital or the hotels are very expensive, it's still much more expensive to stay in the hospital. Much more expensive.
One tenth.
There's one website question. Professor Wang, there's a question ask you what's your energy setting during the operation? Oh, she can answer.
Can you hear me?
Yeah.
The energy setting you mean for bipolar or for harmonic scalpel? Because harmonic scalpel is already set. So for the double bipolar setting, I use the forced the Irby type machine, and I'd like to use the forced one. If we can step up, can we see over here? Yeah. So
you use
this is
any specific. Oh, you use a biosystem.
yes,
Yeah,
Irby now.
I prefer it. Yeah. So you use the additional foot pedal inside the console.
The additional one, the one that you suggested me.
Yeah, maybe I told you. Thank you.
Because initially I found it very, I was struggling to find a good bipolar external generator. Because at the beginning I did want to try using just the left side, and I pushed all the energy to the maximum. But I still can't get the effect that I like. And I remember it was I think in IHPBA in India when we met, and I was talking to you about the difficulty of the bipolar X generator that I was looking, and then you told me about this Irby system, and I was lucky because it was actually there during the IHPBA. The company was there. So after, I meet them, and then when I come back, I try to contact, and then ever since then, I started using it. Yes.
Yeah, the company was also lucky. Yeah.
May I ask, Shinny Wang? Yes.
Yes.
I'm Yoon. You are doing so well.
Thank you.
For this jejunum division, I usually divide the mesentery as close to the jejunum, but Professor Wang is try to this ligate his vessel pedicle. What is the advantage of this procedure? This is for oncologically or this what is
oncologically.
Oncologically.
Oncologically. Yeah. So if it's you can see that this is also a lymph node that I worry about. Of course, maybe, maybe if it's,
but
yes.
I'm talking about this instance of lymph node metastasis. The instance of lymph node metastasis is a jejunal mesentery lymph node.
It's really a hot topic.
I now also believe if it's a malignant tumor, I think it's better if we take the mesojejunum soft tissue along with it. I'm not entirely a fan of entire left approach because it's really difficult. I'm sorry to Professor Nguyen. We're still trying to learn that technique, but we are still trying. But I do believe central dissection and incorporating some of these mesojejunum is good and also important for cancer patient. But if it's low malignant lesions, we do along the jejunum as well, like in the past. Yes.
Professor Wang, if the mesopancreas you found a suspicious lymph node, would you like to send for cryosection? And if the cryosection is supportive for malignancy, would you terminate the operation?
In the past? Yes, in the past,
No, for
in
this
open
case.
surgery. For this case, of course, I did not explore right away, and this should be already being studied on the image, the CT scan. So if we see from the CT scan or MRI, there's obviously huge lymph nodes, then probably this would be not be a case of surgical approach. But
I mean that for this case, if you highly suspect this lymph
I
node
don't.
is
I'm not highly suspecting. I just don't want to leave it there.
okay.
Yeah. I just feel if it's a lymph node, it should be taken out en bloc. Yeah. But I don't come and examine this area during the robotic setting. So of course, if I come here and I see it, I wouldn't want to send a frozen because it's going to bite my tongue. Otherwise, why do I want to do the operation? I just feel that if it's possible that if we can stay along the artery that's supposed to be preserved, this kind of the mesojejunal tissue along with the lymph node should be taken out en bloc, especially for pancreatic cancer or uncinate cancer.
I'd like is Professor Inoue. And so actually regarding the extent of lymph node dissection, many randomized control trials didn't show the oncological advantage of extended lymph node dissection. So could you explain?
I think, yes, maybe Professor Nagaka also agrees with our opinions. It's not for only the lymph node dissection. It's really for the good exposure of the posterior aspect of the SMA, the most critical vasculatures. And in invasive pancreatic head or uncinate cancer, this is the most critical point to maintain the margins or distance from the tumor. For that, I think, in my opinion, the mesojejunum dissection together with the mesopancreas give us the most open field and the margins. What is your opinion, Professor Nagakawa?
Actually, in my data, so the pancreatic cancer, if the pancreatic cancer located on the process, so pancreatic cancer invades that area. So actually, we call this area C. So that area is include the posterior vein. So that's connected tissue that include the posterior vein. So pancreatic cancer often they invade that area. So for me, when the dissect this area, we first try to explore left side SMA, and then confirm the left side SMA, and then we start the dissection around this area. So that is we have the two purposes to dissect this area. So the one purpose is we safely dissect the left side SMA. And then when we perform the right side, so the operation becomes much safer and easier. So if we already expose the left side. And as oncologically, to achieve our resolution, so the cut of the root of the IPDA is important. So if we want to confirm the position of the root of the IPDA, so the posterior vein need to be cut peripherally, right? So in this case, left approach are really useful. So I just want to I just confirm the jejunum vein. It's probably Dr. Inoue also the focus on the jejunum vein. Probably that jejunum vein is derived from the right side of the SMB. Probably, usually, I guess. Yeah. So in this case, so we cut the jejunum vein first. Yeah. So that is for me, its operation becomes safer. So that if we preserve the jejunum vein, probably that vein, to obtain surgical field is a little bit difficult.
This is for only uncinate cancer or all pancreatic cancer?
We apply it for all pancreatic head cancer. And in my opinion, as Professor Nagaka mentioned, we should make this vein to be the specimen side. So we go across here and make it to the specimen side and dissect all the area unblock with the pancreas head beneath the SM A and B.
Because that vein has a many branch
Yep.
of the GM,
Yeah.
like this.
We tend to try to preserve the first jejunal unless it's actually being invaded, then we'll take it. And this one, if I remember right on the initial CT scan, and I think this is a really important point, particularly for people that are learning how to do robotic Whipples, is that the takeoff of the first jejunal vein is very, very critical to the dissection. And I think it's something that you really need to pay attention for and make sure you identify. This one here, if I remember right, actually went anterior to the SMA on the first scan, if I went back, as opposed to doing the more traditional kind of coming out laterally and going then posterior way. So I think that definitely impacts the dissection in terms of the branches, as you've mentioned. So we usually don't, like I said, unless it's directly invaded, then we have no problem taking it. But like was mentioned, we try to stay pretty close to the jejunum when we do these dissections. And so, you know, at this side, we would never see it on this side. But so when we're taking it from the patient's right-hand side, the right hand of the mesentery there, you know, this case would be a little bit more favorable to do because the first jejunal vein is going anterior to the SMA, so it becomes a little bit of a less of an issue as opposed to it wraps around posteriorly. And there's always 2 to 3 small branches that are giving off to the uncinate and the head of the pancreas, so that you really need to be mindful of, because you can certainly get into bleeding around that area.
So you notice in this case, this jejunal vein lands in front of SMA. Wow, during the morning's presentation, you noticed.
Yeah.
Well, great.
Yeah, I mean, I
didn't-
could be wrong, but
didn't know.
I'm pretty sure that was the case. And because I've been burned before in terms of, you know, not appreciating that aspect of it and getting into a little bit of bleeding during the case. So I almost always will try to make sure I identify that, the takeoff of the first jejunal.
Maybe here we can see the first jejunal artery. What do you think? I'm not sure. Still not sure.
Behind the jejunum.
I think that this kind of the dissection using the left side SM approach is useful, especially for the tumor located uncinate process.
Yeah.
So
Yeah.
when you perform the lymph node metastasis, and just the left side of SMA is very rare, except some uncinate process cancer. So this case is a CVD cancer, but I think basically, practically, it is not helpful for the patient with distal CVD cancer. But I think Professor Wang showed this procedure applied to the uncinate prostate cancer. I don't know that this is a routine procedure in the veteran hospital or not.
Professor Chi,
Is this routine
this
procedure in your hospital?
mesojejunum resection is routine for all malignancies.
You mean the way? Now it's not a
Oh,
routine.
only for pancreatic cancer, especially uncinate.
Yeah.
Only for pancreatic cancer that anybody can hear me now.
Okay, no problem.
Okay, and Professor Shi is also on scene.
Yeah, usually, actually, Professor Wang just want to show how she started. Yeah.
This is a
Just pancreatic cancer.
yeah.
Usually
We feel that this is pancreatic cancer, but somehow Professor Chen still thinks this is a bile duct cancer, right?
Usually we just dissect along the jejunum, not away.
In the past literature, I reviewed the
hold on.
incidence of lymph node metastasis on the left side of SMA. It's a very old literature from Japan, Kanazawa group, and they described that incidence was only 2% or something. Yeah.
In the
Not so
hospital,
high.
2.5%.
So I think it would not be the main reason to justify the mesojejunum dissections. Yes, and to be honest, the left-sided approach is already the most comfortable for us. So we apply it as our routine procedure, and we perform it very safely. Yeah. Professor Wang, do you hear me?
Please turn on the mic. So, yes.
Sorry. How do you, dissect and identify and ligate the ligament of trites? You do it in this setting, in these stages. The ligament of
Okay.
trites.
Let me. Can I first take this then, and then I'll try to answer it?
Yeah, please go
Okay.
ahead.
Blue, 蓝的啦 ，blue lock。OK， 可以，谢谢。好。
The best. In South Korea, the many good nurse practitioners assist you. Yeah. And they perform the many cases every day, every week, every month.
Yeah.
So I think the performance of the nurse practitioner is also very good in your country.
Yeah.
Also in the United States, right?
Practically, I think the quality of the assistant by the NP is much better than the resident.
Yeah.
Yeah, I would absolutely agree with that. I mean, ours go back and forth in terms of whether we have residents or nurse practitioners, and the residents that are very engaged, they're excellent, but not engaged.
Of course, in our society, I want to introduce this system, and it aligns with the shortage of surgeons in our society. But as you know, our government is very, conventional or, conservative. So it takes a longer time. But in the near future, we can enjoy such kind of task shift. When I visited the Johnson, any comments?
I think depend on the medical environment, and then shortage of surgeon is related with to recruit the nurse practitioner in our practice. So in Korea, the many of the young generation do not want to be a surgeon, especially for HPP surgeon, unlike the past period. So it is obligation in Korea to use the specialized nurse practitioner in the surgery. With the accumulation of the experience, the quality is improved much better than the junior resident. However, in spite of that kind of situation, if the resident involved in the operation, you would like to give a more chance for the education. During that times, I'm very angry about the poor quality of the assistant. However, that is a duty for the professor. So we would like to give them many chance to experience the advanced surgery into our resident.
In our hospital, because the resident should rotate for each section, not fix in the upper GI, even the pancreas. So initially, I set up the laparoscope or robot. I use NP and fix NP, because the NP can fix to act as the assistant to help the procedure. So it's better than resident.
Do you think high pay for critical or high-risk surgeon will increase the recruitment of eligible surgeon, even in states?
Yeah, and so for us, we actually have
the first jejunal artery.
We have more people that are interested.
I think this
in
will be the
wanting
first
to
jejunal
do...
artery. Professor Wan, is this the first jejunal artery?
Yes.
Yeah.
I believe this is the vestigial artery. So please take. I think for tricep ligament, we usually now we try to. I'll ask my assistant to traction towards to the caudal side, and then we can just use either harmonic scalpel too. So for us,
You don't apply
tricep
creep?
ligament. No, actually I don't. Unless when I do the dissection and I found suspicious vessels or lymphatic tract that I worry, then I would try to apply. But most of the time, I think this area we just use the hormone scalpel to take it down. Yes.
Thank you.
Okay.
Regarding the nurse practitioner system,
Yeah, regarding our training, so there's two ways to do specifically HPV surgery in the United States, and that can be done through the Society of Surgical Oncology, where you SSO trained and you go through that route, or you can do it through the AHPBA, IHPBA track.
听不太到我的好吗？scalpel 声音。
And we actually
是
have
我自己听不到，我不喜欢那样。
to do HPB than there
反过
are
来，
jobs
不要绑，
available.
反过来。
So it's not as much of a reimbursement issue as it is just, in the United States there's a big shit. What we have a problem with is getting primary care doctors, getting pediatricians, getting family doctors, and things like that. Most people want to go into some sort of specialty, whether it's a surgical specialty or something like that. So we have a very difficult time recruiting recruiting from a primary care standpoint, and that's where a lot of the big pushes for nurse practitioners there is to take over a lot of the responsibilities of primary care, for better or worse. But yeah, most people in the United States try to go to surgical specialties or any specialty for that matter.
Because the inducement is very important for young generation devote into the pancreas and HPV surgery. So in Taiwan, since the September, we can increase the nearly double four of the inducement for surgical fee.
Oh, you can increase the income.
Double four, but this is done from Japan, because I asked about the Japanese investment for pancreas surgery from Yamaue. So I used the criteria to ask our government to increase the double four of the pay for the surgical fee.
Yeah, actually, correctly speaking, it's for the hospitals, not for surgeons, individual surgeons in our society. How about
this benefit for private hospital? Because I'm in the public hospital, our salary is
the salary is same. Okay.
not increase more, but in private hospital, the salary will increase.
Is about the left side approach and the IPDA. Do people usually contact approach to the IPDA from the left side or right side? In this case, they just cut the J1, but not for the IPDA.
Yeah.
So I'd like to know the
I think one reason she didn't pursue the route of IPDA is a view angles, because the scope is set from almost the right side of the abdomen. It means it's very difficult to see the behind SMA from left side. So she didn't pursue it, in my opinion. But in our method, or Professor Naka's methods, sometimes we use the midline or left-sided scope position. It gives us a very good exposure of the really posterior side of the SMS. So in our series, we ligate the IPDA in 90% of cases from left side. Yes.
We do most of ours rather from the anterior right side or from the posterior right side. One of the the benefits of the camera here is the camera's been 30 down the whole case. But if you're doing and getting a really generous Coker maneuver and you lift it up, once you've transected the jejunum and you lift everything up, you can actually do 30 up on the camera, and you can see the IPDA there will come off vertically. And so once you have everything lifted up, yes, you can come right along the SMA and you'll see the IPDA going or anterior abdominal wall like that. So it kind of depends again on the body habitus and a number of other situations whether we'll try to get it from the SMA from the right posterior approach or the right anterior.
Yeah, turning the scope is very interesting. Yeah, very nice idea.
It is very tough. In most obese patients, I'll get it anteriorly from the right. So we'll free up the whole SMV portal vein. We'll take the vein of Belcher's, the superior vein, and then that means the vein's completely free. So then we'll usually loop the vein, retract it to the patient's left, and we'll get anterior on the SMA, come right down on top of it. And then once you do that, you'll be able to peel the tissue away, and you'll see with a good lateral retraction, you'll see the IPDA coming off laterally, and then you can clip in ligate.
Now I think it's very good timing for dividing the pancreas and to make the better exposure of the SMV and A. Oh, now she's mobilizing the hepatic fracture, yeah, to give us the better exposure of the pedicle of SMAV. Yeah. Do you perform this as a routine, as you mentioned? You routinely mobilize. Okay.
Procedure. The divide this colonic hepatic fracture is very useful to provide a better view.
Especially as the BMI goes higher, this is absolutely critical. Yeah, absolutely critical. Otherwise, you have a very difficult time seeing around the uncinate.
Yeah. So another.
Can everybody hear me?
Yeah.
Yeah, this is. I completely agree with some of the experts, commentator was saying. I don't do a routine takedown. I only do it when I feel that it's in the way. So that's why I'm doing it now, because today the patient is a little bit too fatty, and so sometimes you get really slim patient, then this is not necessary. So I don't do routine, but I would do that for cases that I feel it's in the way and very obese. Yes, yeah.
Thank you.
Okay, thank you. 那个3条再来。好。
May I ask? I can see the JP drain now. Why do you place the JP drain?
Yeah, it's very
time?
unique. It's very unique.
Yeah, why?
I hear that
That's actually
it's the most simple to insert before docking.
Yes, that was also explained.
If you place the drain after the procedure and the robotic machine is still there, it is a little bit for our bedside surgeon to place the drain. So before docking, we use a laparoscope and place the back drain first. If you see the final procedure, you will see the drain is behind the liver.
Okay, so 等一下，你先清 camera， 然后我们要给他们看一下。Okay， 对，你清 camera， 然后等一下看他们。So, yes， 我要讲，等一下。
Okay.
Can everybody hear me?
Yeah, I hear.
Okay. So now we are doing the transition of the robotic arm 3 to the central part. This is a part where we want to do the mesopancreatization. Originally, we just do trocar in trocar, but now because we have the wound protector, we can just add a 8mm trocar on the wound.
And in this movement, you need a redocking of arm 3, right?
It's already done. Yeah,
okay.
It's finished.
Very quick.
The redocking is already done.
Excellent assistance.
你叫那个摄影机把那个镜头照靠近陈世清那里。
OK。
靠秀 Edmond。
好，那你可以再进来一点，没关系。这时候没关系，不要。对，可以。哦，好。这个我污染了。 这个椅子问 Can everybody see this part?
Not yet.
Not yet.
Not yet. Okay.
One international question is want to see the yeah. I don't want you. Okay.
Okay. Oh, you use the 5mm assistant port here. You also. Wow, very
Yes.
good. So you use the 3 assistant trocar right now. 1, 2, 3.
Yeah.
Yes.
This way we can have 3 assistant trocar. But in the past, when we did not add the wound protector, we usually the 8mm trocar goes into the 12mm trocar. And then my assistant will be on the 8mm trocar on the patient's left side. Yeah. And we have a 5mm assistant. Yeah. But now, because of the from Professor in Norway inspiration. Yes.
Now most of the time we make the big incision over the umbilicus because we always extract the specimen from that. So before docking, we set up the silicone base and put the 2 trocar, and then we have additional trocar. That's good.
但我现在要断 neck， 所以可能要给我。
In total, do you use 7 trocar during the procedure?
7.
Yes.
4 robots and 3 assistants.
But the same incision. The same incision.
Rhizotomy position for the assistant have the more space.
Yes, more space.
Rhizotomy.
Pardon me?
Lithotomy.
Rhizotomy position.
For pelvic surgery. What just split?
You
or
mean the
lithotomy?
Yes. And we can extract the specimen earlier. Before this one, we always extract the specimen after all the procedure. Once we finish the destruction part, we extract the specimen from this big wound.
Yeah, it's very convenient.
Yeah, very convenient.
Yeah, especially in invasive cases, we should check the stump area, maybe before reconstruction.
You mentioned checking the stump. What margins do you send for those that do frozen? What do you send off? What margins do you check from frozen?
Yes, in every
But do you check uncinate margins, you check pancreas margin, and you check common bile duct margin?
Yes, always. Once we, as I mentioned, once we finish the destruction part, we take the specimen out from the umbilicus wound.
So yeah, so we check the pancreas margin, the bile duct margin, but we don't check the uncinate margin in surgery. Because if you get an uncinate margin, it's positive. Do you resect the SMA, or how do you approach that?
Just pancreas cut margin, bile duct margin.
So just those two, just the 2 margins.
Yes.
Yeah. That's what we do.
And if the tumor adheres to the vessel, we just cut the vessel.
We do, yeah.
In a very exceptional case with the so-called borderline resective case, which attached to the SMA, we sometimes dissect and submit the small piece of the nerve plexus intraoperatively before resections. Yeah. Sometimes we have to convert to the open, or we have to discontinue. But we indicate the robot to a more, less advanced case. So it doesn't matter in most of the cases. Okay, now we should discuss about how to divide the pancreas. Yes. Dr. Wang performs very good dissection division of the pancreas using harmonic scalpel. I think it's the most broadest. How about your opinion? how do you dissect?
So it's about 50-50 whether we actually complete the tunnel completely. If we do complete the tunnel, I'll put an umbilical tape through it and lift it up. And so we'll have some of that. We used to, like we would do open, we used to put in a couple stitches, inferiorly, superior, and do it. But we don't do that anymore. So the way we come across the pancreas is I'll use the thermal scissors and I'll turn it up to about 6 or so. And then I'll kind of do very similar to what's being done here. We almost kind of apple core it out in the sense that we leave the duct like that. We take the duct into the specimen a little bit, so that way a little bit is sticking out exactly like this. And then when we're transecting the pancreas, we take it a little bit at an angle. So I want more sticking out posteriorly and less anteriorly. So I take a little bit of a slight angle just because that makes the PJ, I think, come together a little bit nicer. But we usually completely transect it with the vessels, with the thermal scissors. But I know there's some people too that once they transect the duct, they take the rest with the robotic vessel sealer. So I know some people do that.
Is there any comment from other groups? How do you divide pancreas?
So sometimes we use the hammer scalpel, especially the inferior side and then upper side. However, when I use the energy device during the division, some thermal injury make a shrinkage of the P duct, especially in case with the small P duct. So recently we do not perform the hammer scalpel division. So at the border of the upper and the lower border, we use the energy device, including the hammer scalpel, to treat some vessel. However, in the center of the pancreas, we only use the scalpel with the bleeding to preserve the vessel to the P duct and then to avoid the shrinkage of the P duct. So usually after the bleeding cut margin, we can find the P duct exactly and then compress use the gauze. It's a very useful tip to reduce any injury to pancreatic duct, especially those with a very small P duct. And then also Which said that the transection line is very important. The slightly oblique transection line is useful to widely showing the pancreas margin, make a perfect ductal mucosa anastomosis.
Thank you. Any comments from Professor Nagakawa?
Okay, so my procedure is almost same that Professor Wang procedure. So I also prefer to use the hammer scalpel to transect the pancreatic. But sometimes bleeding occur from the cut surface, especially the superior border of pancreas and the inferior border of pancreas. During the surgery, we can stop it, but after the surgery, if the POP occurs, sometimes the bleeding occurs from the cutting surface. So probably most surgeons ligate around the superior side and the posterior side, inferior border of pancreas to the ligate pancreatic parenchyma to prevent the bleeding.
Yeah.
So we always ligated it.
Yeah, as Professor Jiang mentioned, the location of the pancreatic duct, especially in a very small duct, is very crucial. Sometimes we get lost of the location. So in every case in our groups, we performed intraoperative ultrasonography to precisely identify the position of a pancreatic duct. And in our group, we prefer to divide the pancreas by using the bipolar. It's very bloodless. And most of the cases, we applied encircling of pancreas neck, and we applied flat intestinal clamps to the distal side, and to the proximal side, we use the cotton tape as a tourniquet to control the inflows. And we divide meticulously using the bipolar. And if we reach the position of main pancreatic duct, assistant scissors will cut sharply that area together with main pancreatic duct. And afterward, we divide the remnant pancreas using the bipolar. It's our method.
Some surgeons prefer to use a stapler to divide it
Yes,
to bring the
exactly.
That is one option.
Yes. it's really bloodless. Yeah, but we have to detach the many crypts, many staples before reconstructions. But our group also performed that kind of staple divisions, and we sometimes we have published one retrospective articles. The staple division reduces the incidence of POPF because they close the branch duct, so they even prevent this minor leakage. So we need a randomized control trial. Yes.
So if you use the GIA for the treating the stump,
yeah.
So you open just the center of the pancreas parenchyma?
Yes.
Okay.
Just around the main pancreatic duct.
However, in case of the thick pancreas,
big mean big duct.
Yeah. Thick pancreas, it is very difficult to.
Thick.
Yeah. It's very difficult to
That's
treat the pancreas parenchyma without the rupture.
Yeah, in my opinion, it's up to 2 centimeters. We can apply the stapling, the method. If the patient has 3 centimeters thickness, we use the bipolar.
Would you like to describe what technique you use endo-GIA, how to spare P-duct?
Oh, yeah. In robotic surgery, we can easily find the stump of the main pancreatic duct on the staple line. Yes, it is somewhat very whitish. Even if the diameter is 1.5 millimeter, we can find it. And if it was difficult, we can use ultrasonography to estimate the position.
I'm asking that how you apply your endo-GIA to spare P-duct. Because usually P-duct usually at the upper third bottom area. How can you complete your endo-GIA procedure?
Oh yeah, we staple the P-duct together. Yeah, together with the pancreas parenchyma. We all close the pancreas duct, pancreas stump. And afterward, we find the stump of a P-duct and detach the staple around the P-ducts. Maybe 8 or 9 small staples. We make it open again and anastomosis. Yeah. I think so, yeah. In hard pancreas, we just simply cut.
How's about the popularity in Japan, using the GIA to treating the pancreas stump?
I think its popularity is increasing. Yes. Bipolar. Yes. In my personal opinion, I don't like stapling because detaching the stapling is very troublesome for me. Yeah. 15 minutes sometimes. 15 minutes. Okay, now the Professor Wang is approaching the SMA, mesopancreas, the lower edge of the mesopancreas from the right side. Yes, and thanks to the change of the robotic arm position, the angle of harmonic is now very aligned with the angle of SMA. Professor Nakakawa, we should regard this triangle area as an area D in your criteria?
Yes. Actually, we call the connective tissue between the ancient process and the posterior side jejunal mesentery. We call this area D. So the area D is include the lymph node, also lymphatic duct, also the some fiber. So actually in our data we found that the pancreatic cancer often invade exactly this area. So to achieve the resolution that we routinely dissect this area.
So
And
you do not divide here or detach from the SMA for this layer or divide in this line?
Yeah. So the procedures are almost same. The Professor Wang. We always confirm the position of the SMB and the bifurcation of the SMB, and after that, SMA or SMA nerve plexus is also the confirmed, so that it's located behind of the SMB. After the confirmed the SMA nerve plexus, and then area D is isolated from the SMA nerve plexus. Actually, there is a loose connectivity between the area D and the SMA nerve plexus. So the probably Professor Wang already confirmed the loose connectivity and they exposed it. And then yeah. And then Dr. Wang completely clipped the area D and they cut it. Actually, the colleague they often walk out at this area, so they will always cut it before cutting. We can see the many delivery ducts here.
Yeah. I think this is also the liver duct. Critical area.
Does anybody use ultrasound or ICG here to help identify, whether it's the SMA or IPDA, anything like that?
Sometimes.
Yeah, I've been a big fan of ICG, in these situations. You kind of dilute it up and you don't have to give much. It's, 2.5, 3 milligrams, something like that. And it really does a nice job in terms of highlighting, whether the IPDA takeoff or the SMA itself, particularly if you have a lot of fat and you're digging in there trying to expose that area. I think the ICG can be incredibly helpful in that situation.
Yes, but in a fat-rich patient with a belly thick mesopancreas or belly thick mesojejunum, but simple administration before dissection doesn't work in my experience because of the thickness of the envelope.
Detected the SMA or IPDA by the ICG?
Sometimes both. It depends. You're right. The ICG, even if you give it at a high concentration, still has a very difficult time going through a lot of the fat. But as you get closer, and maybe you still haven't found it yet or whatever it may be, whether it's the IPDA or whether it's the SMA itself, I think ICG is very helpful in terms. Useful. I think so because it costs you nothing. I mean, cost as there's no complications from it really, so I use it quite liberally in terms of really trying to define my anatomy to making sure I know exactly where everything is. And especially helpful, sorry, the last part about that, it's really, really helpful too if there's a replaced right that's coming off the SMA, because that can really then highlight exactly where that is as you're doing your dissection. So I think it's very, very important in those cases especially.
When do you use the ICG? I mean, the first of the operation or just in this setting?
So when you give it for vasculature, particularly for the artery, it takes about 30 seconds to work. So it's really quick. So what I'll do is it comes in basically 25 milligrams in a bottle. And so I'll have the anesthesiologist rather drop 1 or 2 mLs. I'll have them dilute it into 10 mLs. And then I get ready to what I have exposed and what I'm questioning. And then I'll switch over to the Firefly and then I'll have them give it. And in about 30 seconds, you'll see it start to come through and everything lights up. Yep.
So, Professor Zhang, do you routinely use the ICG for the dissection?
No, I don't use. So, usually the dissection from the right side after the derotating the jejunal side to the right side, so we have no problem to identify the branch from the SMA. So usually we do the dissection without the ICG. So I would like to ask some question to all of the international members. So based on the currently AI or some kind of the reconstitutional method, we can use the reconstruction of each small branch from the SMA, SMV before the operation. Some group use that kind of the technique in designing the operation. So how's about the situation of each country for applying that kind of the AI advanced imaging technique before the operation?
How about Japan?
Yeah. In our society, the preoperative simulations using the 3D reconstruction by the very thin 0.5 millimeter CD, dynamic CD, is very common. And of course, in every case in our society, our young fellows draw the very detailed pictures, as you know. And this is very good training and very good for clinical practice. But sometimes the problem is, in the rotated anatomy or twisted anatomy, the identification of each vessels is sometimes difficult, even if we inspect deeply by the preoperative findings. So some surgeons prefers the very big rotation of the pancreas head. They call it a light lateral approach. In this case, the SMA is rotated more than 180. In such a case, which for me it's very difficult. But anyway, to inspect the very small branches by the preoperative images is very crucial. How about your opinion, Professor Nakakawa, Professor Hirono? You do it.
Yeah, of course, the education, right? So before the operation, checking the location of the IPDA and some branch of the SMA is really important. But even we confirm data during the operation before surgery, so during the surgery, we sometimes confirm another the IPDA, that branch of the IPDA, SMA. So anyway, the careful dissection of the SMA is really important.
Yeah, we find the undetected small branches, yes, in often.
Professor Yang, how about in National Taiwan University?
We usually, before the Huipo operation, in every case, we use thin slice CT and also reconstruction by the program. And also we like to do angiography before operation and to make sure any variant of the vessels.
It's the most sensitive, right?
Yeah. Angio is more sensitive. So usually about this topic, how about if the variant right hepatic artery from SMA, but a little contact of the pancreatic cancer, what's your strategy? You do upfront surgery or?
The tumor contact to the replaced. Yeah, neoadjuvant for us.
You mean commercial program is? Yeah, Japan. Not so good. It depends. Depend on because before you want to reconstruct the image, you need to cooperate with the radiologist to do a good CTA protocol. Yeah.
It depends on the quality of original CT scans. Yeah.
Dr. Liao, I think can you describe in our hospital how to evaluate before operation?
Yes, thank you, Professor Chen. So in National Clinical University Hospital, we perform a 1 millimeter CT scan, and also we have like a surgical board. So we review the case 1 week prior to the operation, and to check the arterial aberrancy. And of course, in a case of pancreatic cancer, If T4 case is suspected, we always do a neoadjuvant chemotherapy first. And during the MTT team discussion, we will see the tumor response and go for the operation.
How about resection of replaced hepatic artery?
Yeah.
Do you reconstruct or you do not?
In previous experience, we do not do reconstruction, but recently we have one case. He suffered from recurrent cholangitis, and
liver abscess.
Yeah, we don't know if it is related to the replaced right hepatic artery resection. Yeah, so after the Whipple procedure, that the patient suffered from several times of BTI, so the adjuvant chemotherapy is a little bit difficult for him.
So if you still, yeah, please.
Yeah, we approach the decision very similar to you. So we start, if it's involving a barren anatomy, we always give neoadjuvant as well. And then when we're doing the procedure, if it's still involved and we can't divest it off, and you do have to take the vessel, we approach it very similarly to the way we would do a distal pancreatectomy and celiac axis resection, is that we do two things. So we clamp up high on the distal portion of it and do a hepatic ultrasound just to see, is there good flow on the right or is there not? The other thing we do as well is we, if we're debating on whether or not to clamp it, when we ligate it, we'll release the distal clamp and then see. And if we get, pulsatile back bleeding from that, then we don't reconstruct it.
Okay.
Excuse me, gentlemen, for the interruption, but it's about lunchtime. So if you want to still want to watch the live demo, you can go outside and take your lunch bags using your lunch coupons, which is inside your badge. And then we'll still continue watching the demo section.
Yeah, I think this is very important for us to
sure.
No one here wants to eat lunch right now, so
lunch box are reserved for you,
30
but
minutes or later.
Yeah, sure, but you can take it anytime. But remember to take the lunch box so that you cannot.
Okay.
Yeah,
Thank you for your
be exhausted
guidance.
for the whole session. Thank you very much.
Yeah.
This is today's point, important point, key point.
Key point. So from now we are approaching to the belly critical point. In my impression, this arch would be some jejunal arteries. SMAs from here and the jejunal artery, maybe second, comes from here and lands behind the SMA. So we should approach to this line. And we find some IPDS from second, JA second. And sometimes we cut the peripheral side and make it to the specimen side and ligate again the origin of this arch.
I just want to make a comment on this as well. As far as the exposure, I mean, beautifully below, you can see everything here very, very nicely. Another consideration would be to, like I mentioned, I try more and more now to get the vein completely off. And you can loop the vein and pull the vein over to the patient's left, and you can have rather the bedside assist hold it, or you can do it any number of ways. And then instead of coming, because we're still coming on a little bit of the lateral aspect here, then with the vein all the way over, what you can do is actually go completely anterior to the SMA, get on the SMA, because there's almost never any branches that go completely anterior on the SMA. They're almost all lateral or posterior. And so then you have a very clean plane, and then you can work the tissue down. And then when you get to this area here, you have it already quite nicely exposed. And the vein's already over too. So that's another kind of consideration. It does take a little bit more time, but obviously when it comes to this, there's no more important part of the case. So I think it's worth it.
So in your procedure, you encircle the SMV in this situation and retract. Yeah, great. Yeah.
So that is a useful tip to using the surgical loop to retract the SMV to the left side. As I think the optimal retraction of the pancreas head and duodenum to the right upper side.
Yeah.
De-rotating the SMA root side to the upper side is very useful to show the posterior side of SMA.
Yeah.
So also the retraction of the SMA with the left side and lifting the pancreas and the duodenum to the upper side. It is very useful to widely showing the space between the originate process and then SMA.
Yeah, good indication. It makes SMV more shallow. I mean, yeah. But in my expression, maybe the professor wants him retract the duodenum or pancreas head to the right side already. What do you think? Professor Wang, you hear me?
Please.
Oh, I'm sorry.
Can
I
you?
want to
No,
ask you
it's
a very
okay.
quick question. Do you retract?
Yeah,
do
sure.
you retract the pancreas head toward the right direction in this situation?
Yes, I'll show you. I'll show you in a minute. I'm just struggling with the vein.
Ah, here. Okay, okay.
Yeah, I always use the forearm for the retraction. Yes.
And your assistant pull the SMAB pedicle to the left side.
Yes.
Your
Yeah.
assistant.
And
By this.
sometimes, if I feel it's necessary, I also agree with. Sorry, I can't remember. One of the commentator is looping the SMV. Sometimes I will also do that if I found the part of pushing the SMV, SMA not so efficient by my assistant, but of course you can see they're doing a good job, then I don't think it's necessary for me to loop the SMV. But if I found it difficult for them to expose, and if I found there's a significant evidence that I probably need vein resection, then I will start looping everything.
Yep.
You can see today this is a very fatty and easy bleeding case.
Yeah, yeah.
Sorry.
I hope bipolar dissection works well. Yeah, in this
Yes,
situation.
it is.
Yeah.
That is actually the advantage of bipolar, double bipolar especially, in my opinion. Yes.
Thank you.
And this is where, too, for the DV5, the curved vessel sealer can do pretty nice because the tip on it is pretty nice. Because where I trained in fellowship, the way they did it was the Pittsburgh model with the bedside assist being an attending or a second-year fellow, and they would use the Maryland ligature for that, which is a very nice device as well, like you mentioned, for any number of reasons. But on the DV5, it's the curved vessel sealer is a very similar profile, so then you get control of it there. But yeah, I think the bipolar, I think the ligature or the curved vessel sealer, those would be the three best, because the robotic vessel sealer is way too bulky for this dissection. You could not get near this type of fine dissection in that situation.
Yeah. Maybe the new device will be the game changer of robotic dissection. Yeah.
这边要稍微压一下，对，因为
Very good assistance.
Is this a J2 or J?
Yeah, in
What do
my
you think?
first impression, this would be the peripheral side of J2,
J2,
jejunal artery.
yes.
So we have to doubly ligate from peripheral and the proximal. So we have to follow.
This is distal side of J2.
I think so.
Uh-huh.
Yeah. But I'm not sure. But we often find this kind
Then-
of arch
yes,
shape.
then proximal is
Yes,
upper side.
is yes,
Uh-huh.
cranial.
Yeah, probably.
Action. We can see the outline of SMA here. It will be a
Proximal side of the J2A.
Professor Nagakawa, which portion is SMA3 in this view? If you want to use this button.
This patient has no passage vein branch from the right side of the SMB, probably. So usually the passage vein branch from the right side of the SMB, and then they go like this and they pass through the
So this
posterior side
patient
of SMB.
doesn't have a PDJB.
Yeah,
you
PDJB. So
mentioned.
we call this one the
Oh,
PDJB.
so Professor Hewitt, the inspection was very correct.
Yeah. And
Very good.
so probably this patient that has a PLGB, that means that's derived from the left side of the SMB and the pass through the posterior side of the SMA. So probably just vein that's still located around here, I guess. But in this case, probably the SMA nerve vessels is already exposed like this. So that we actually we call this area the SMA3. So that it's also the really good landmark before starting the SMA dissection because I already confirmed this position. But so probably that this case, there is also the still connectivity around here, right side SMB. So even though we reconstruct the duodenum to right side, so probably that we cannot still obtain the good surgical field around here. So probably now Dr. Wang want to dissect around here, and after that put this side. Put this jejunum vein in the right side, and then probably I guess that we can obtain the good counter traction around the IPDA, I guess.
Thank you. Yeah, I think so. Yes, the ligated vessel is the pancreas head branch from dorsal. Yes. This one, this stump. Oh, lunch here. Right. Thank you. very sure ligation. In this situation, the good contact traction between the pancreas head and SMA is crucial. And the TBGH group has a retraction of the pancreas head using the arm 4, and they are very reliable assistants. Works as a counter traction using this device. But for example, in our group, we use the carrier for SMA retractions to the left side, and right-sided the retraction is done by the extracorporeal retraction using the end loop system. Maybe, yeah. Because this is the second, this is inside. It means yes, yeah. But there is also the arch. Maybe the peripheral side is clipped from the left side, but that was not origin. Yeah. So maybe we can find IPDA here. Yes. So which line does Professor Wang choose? From this line or along the outside? Yes. Both is okay in this case, yeah. This would be the IPDA. IPDA, yeah. Oh, what was that? What was that? I'm not sure. I'm still not sure. Professor Wang, is this the IPDA from first jejunal artery, common trunk?
Yeah.
Okay, I agree with you.
Yeah. Okay. How? Thank you. 左边再打一个。
Dr. Inoue, is this J2? Probably this is the proximal side of cardiac side of J2.
I mean, obviously it changes with every case we do, depending on the anatomy, but that's why I think it's really, really important to get right on the SMA, and then you're going to, generally speaking, you deal with less branches, right? The farther out you go from the SMA, these you're going to deal with many more small branches, you know, and so that's why, like I said, when the vein's completely off and you get on the anterior SMA, you can take the vessel right at its origin there. And if you do happen to take one of the jejunal branches, then obviously you check the small bowel and make sure it all looks okay. But very rarely does that really devascularize your your reconstruction limb. There's almost always really good collateralization. So I think where I've gotten into more trouble on the SMA dissection is the farther away actually that I go from the SMA, the more trouble that I get into, because there's just way more branches there. Personally.
Professor Hewitt mentioned, what is the tip to exactly go along with the SMA in this situation? Is there any tip to make the good exposure interactions or find a good layer?
Actually,
I think this section is a little bit, far from the SMA outermost layer.
Yeah. Professor Wang already confirmed the position of the SMA nerve process before starting the SMA dissection. So the so my procedure are almost same as Professor Wang procedure. So the first I will confirm the posterior side, distal side of the SMA nerve process, and then we look the closer and confirm the nerve tissue around the SMA nerve process. And then we always try to confirm the running pattern of the nerve tissue.
The direction.
Direction of the nerve tissue. Nerve tissue. And then if we decide, okay, I preserve this nerve tissue, and then we start the dissect connective tissue around the one nerve tissue around there, like this.
Oh, so you keep the same layer?
Yeah, same layer. Okay. And also to keep to maintain, preserve the only one nerve tissue. Only one nerve tissue and the dissected.
Okay. That's a point.
You describe you must differentiate from pancreatic tissue and nerve tissue along the pancreatic tissue margin.
Yeah. Actually,
but it's very difficult in the endoscope.
Yeah, but if we look at closer, we can see the only nerve fiber.
Yeah. In robotic
It's one of the advantage of the robotic surgery. So we can see the really detail of the anatomy of the nerve tissue.
Yes.
So if we find one nerve tissue and then just precisely divide the right along the nerve tissue, so that we can precisely preserve the nerve tissue. So actually, that is one of the big advantages of robotic surgery.
Okay.
I agree with Professor Nakakawa. In most of cases, with a very magnified view of the robotic system, we can find the direction of the nerve tissues along the SMA. So if the direction of nerve tissue is longitudinally along with the SMA, it's an SMA nerve plexus. And if the nerve plexus goes, vertically from the SMA, it will be the PLPH2. I mean the mesopancreas nerve tissue. So we can divide it. Now she's approaching to the PSPDB finally. Usually this is a goal of mesopancreas dissection in most of the cases.
That's nerve tissue. That's one question about pancreatic cancer invasion. Pancreatic cancer is very easy to touch.
I think this is upper end of a mesopancreas. This is a thick nerve plexus from the origin of SMA. Or maybe already the right celiac ganglion. It contains very rich nerve fibers and lymph ducts. So I agree with Professor Wang to ligate it with clip. In my impression, this is the lymph node 8P. Do you think that? In my impression, this is the lymph node 8P here. Yeah. And it corresponds to the nerve plexus from the celiac ganglion or the celiac axis. So if we want to dissect this lymph node, we have to divide the nerve plexus from celiac axis and the celiac ganglion. But it is almost done. This would be the left gastric vein, stereo side.
Professor, what do you think about triangle method? So that I feel that the triangle method only focus on this area, but dissection around the SMA is this side is much more important. What do you think about that?
Yeah, it depends on the tumor locations. And originally, they described the triangle method for maybe locally advanced pancreatic body cancer, not for uncinate. So, but I think its meanings become more widely interpreted. So I think a triangle is focusing on the locally advanced between the celiac and the SMA. Of course, I think for pancreas head cancer, the dissection, precise dissection along the SMA is more crucial. And also triangle, or in so-called triangle dissection, they dissect the nerve plexus along the celiac axis. I think it has a very limited indications. we need a very, precise definition of the terminologies we should discuss further. Almost done. Okay, the mesopancreas dissection is completed. Very good. So now we are reaching to the bile duct. And I hear that in the TBGH group, the cholecystectomy is usually for residents. So after division of common bile duct, the Professor Wang can eat her lunch. But I think today's case is a special live surgery. Maybe she performs a very quick cholecystectomy by herself.
Okay, so
yeah, well done.
Thank you. We are now changing back to its original arm 3.
Okay.
We finished the trocar in wound protector. And yeah, you are right. Most of the time when we comes to cholecystectomy, we ask our residents to perform. But today is a special case. I don't want to waste time. So I'll continue the procedure.
Okay. And yes, and the gallbladder seems a little bit, enlarged and not so friendly. So
yeah. Today we have monopolar scissors, so I think I can do a fairly quick cholecystectomy.
Yeah.
And about the artery, I don't think I snaked JA2. I think probably JA1 was treated more than once.
Okay.
But we can see after maybe the jejunum whether there is congestion or not.
Yeah. Thank you.
Okay.
哎，心怡，其实时间还很早哎，你要不要大家去休息一下，然后看看谁要拿锅杯的 ？Because we start earlier. Actually, we start at about 7, so we finish the dissection part now, about 1 to 2 hours before our usual schedule. As the Professor Wang mentioned, usually it is a time for our resident to practice to take out the gallbladder using the robotic system.
要不要看一下？所以听得到。
听得到，我觉得你可以去休息一下。
那我就是不会累了。不过那我就让曼宁下来拿嘛。
好啊，那个谁啊？
就曼宁下来。
Rita 已经帮你准备咖啡了。
没关系。
I ask Professor.
So we'll ask our fellow Mandy to do the cholecystectomy.
One of our fellow, yeah, to continue the cholecystectomy.
Anyway, we have a dual console. Please just 我们 video 放这边好了。转过来看这边 ，Yeah. We also in this room, room 51, we actually have a dual console. Well, like Professor Shi said, if everybody is okay, then I would allow my fellow to take out the gallbladder while we monitor her.
Yeah, it's okay. Yeah.
And then we can take turns to have a quick lunch. So I think Chen, 志清，你下来这边，然后轩宇站上面。Shall we just leave one assistant at the bedside and then we have someone to monitor our fellow? 志清，对啊，那然后我先吃的，再换你。
Anyway, Professor Wang, we enjoyed your great dissections. Thank you so much. And I hope, applause.
Sorry, it's
you can
a
have
little bit difficult
some
today.
quick breaks with your lunch. Yeah.
Okay.
And we are really looking forward to your reconstructions. Yeah.
Okay.
Yeah, please, Jack.
Takes much time to for the delicate dissection, but I have some experience in to observe the operation performed in Shanghai hospital, region hospital. They just use harmonic to dissect along SMA very efficiently, and to complete the whole dissection maybe very short time.
Yeah,
so my question is, what's the opinion from the every expert? Is it safe to do that, or is what's your suggestion about this dissection? Yeah, thank you.
Okay, it's very okay, Professor Hughes. Okay, okay. Of course, it depends on each hospital's, each surgeon's principles, and hopefully, we want to, achieve the zero mortality. So we don't mind to take a time for shorter procedure. And I noticed during this live surgery, they applied double clips for all the arterial stumps. I really agree with that. Yes. And so they performed one of the surest procedures and surest ligations and surest dissections in the world, in my opinion. And of course, quicker we can do it. We can, omit some, deeper dissection, some ligations, and some, layer to layer dissections. We can make it quicker, but it's not my principles, and probably the Professor Nagakawa's, Professor Yun's principles. It depends on. But I know that in a Shanghai group, they have to perform more than 3 or 4 whipples per day. So in such another situation, they have to perform. They have to prioritize the rapid operations. Any questions?
Oh, okay. I have seen the operation in Beijing around 10 years ago, nearly 10 years ago. Actually, I admit the operation very quickly. But at the same time, I also see a complication. They get the stage 2 cause massive bleeding in the SMA, just vessel just growing from out of the SMA margin. So I think every surgeon want to perform the operation quick and precise and clearly, but you must be careful. Sometimes the accident will happen during the rapid, quickly operation. And second is pancreatic cancer is totally different from other cancer because pancreatic cancer will induce severe inflammation. It causes tissue contraction. So that's totally different from other cancer. So if you perform the pancreatic cancer, you need to be very careful about the unseen process area, especially pancreatic cancer. Unseen process area.
Yeah, I 100% I agree with you. Hey, how about you?
Yeah, so I think the double double bipolar devices, whether it's the curved vessel sealer or the ligature or anything like that, just in experience, they can come across almost all vessels, and I feel very comfortable with that, except for the IPDA. I always make it a very clear point to try to dissect that out, and I clip and tie it because I've had a clip on it before, and I've retracted it, and it gets caught in my instrument, it pops off, and that's a devastating situation. It's a very difficult, because it retracts underneath, it's very difficult to stop that bleeding. So other than the IPDA, I generally would probably go more so with the double vessel sealer. Like I said, whether it's the ligature, I use the robotic vessel sealer for those curved vessel sealer. And I'll double burn, things like that. I think it does a pretty good job of not only sealing the lymphatic channels, but also some of those smaller, any of the veins it does a great job with, and even some of the smaller arterial vessels. But the IPDA is one that I feel very strongly on. You should highlight it and clip across it as opposed to just coming up it.
Okay, thank you. Professor John, I know your operation is very fast. What is your opinion?
So depend on the hospital condition, we must decide the operation time. So as a Professor Wang, and then you said that keeping the principle of the operation is very important. Every hospital has a different principle. So I also visit the Shanghai group, also the Beijing group. They are so fast, very effectively. So our groups also perform the 2 Whipple, robotic Whipple per day. So we do not do the unnecessary procedure. But in this live video, Shinny Wang group showed each kind of the necessary step for the pancreatic cancer. That's the reason why it took a longer time than the usual cases. That's the reason why I think it takes more time. But anyway, another big difference is the energy device. Many of the Japanese groups use the double bipolar technique. It takes longer time, much longer time. However, can provide a beautiful view because there is no fog induced by the harmonic scalpel. So to make a close the surgical view is possible to identify the nerve vessel, lymphatics, and the fine branch of the vessel is possible. So that is the principle. However, in most of cases, I think not useful in many of cases. So just dissect using harmonic scalpel with the rigate to one side is enough, usually enough, no problem. But they want to use the surgical principle. That's the reason why there's some great difference of the surgical time and then efficiency. But we must respect each hospital's surgical principle.
Thank you. Very good comment. Yeah, actually, the Shanghai group is really exceptional. As you know, they perform more than 3,000 pancreatectomy per year. So we cannot mimic them, but we can follow our own principles for the patients. Now they are approaching to the triangle of calot. Maybe they are seeking the CVS. In Taiwan, do you need the specific certification from the intuitive company to perform the console surgeon? No. Okay, it depends on the country.
Oh, in Taiwan, surgeons who want to perform the robot surgery, you need to get a license from the society.
Society, not from the company.
Not from company.
Okay.
Now from the society, gastrointestinal surgery society, robot society, colorectal surgery society, and liver society.
So, but is it difficult to obtain such kind of certificate?
Not the certificate, but was given from the society, not from the intuitive company.
Okay.
Initially, from the intuitive company, such as me, I have seen the operation in the surveillance in Korea, 2014. But in recent 3 years,
In the past, you need it.
Yeah.
Okay. Still, in our country, still we need the certification for all surgeons from the intuitive company. Yes, it's very troublesome for us. Yeah. So our legends have to wait. How about Korea?
That is a different situation. I think to use the intuitive surgical Da Vinci system, they require some basic education through the web page or the dry lab and then animal lab to get the guarantee to the qualification. However, it depends on the situation. In America, especially, they have the very delicate education program. The basic requirement must be done by the intuitive surgical. However, for the specialized system, they have the TR20, 200, 300, 500 system. So that was depend on the institution and then association of the each subspecialist system. So in Korea, also the requirement by the intuitive surgical system, the qualification is done by the intuitive surgical itself. However, for the advanced surgical course, that must be related with some academic association to get a specialized training program.
It's very similar situation. Yeah.
You can talk about your detail.
Yeah, in the United States, so it ultimately all comes down to whatever the hospital requires. And most hospitals do require what has now been a pretty standardized system through the company. Like you mentioned, 1, 2, 3, and 4 level. It's a little bit different as opposed to you coming out of training versus if you're currently an attending and you want to switch over to the robot. The systems are a little bit different. If you come out of your training with a certain level of experience, then all you need to do is have a proctored case. Usually up to our institution requires 3 proctored cases, and once you do that, then you get signed off on. If you're starting fresh on the robot, say you've only been doing laparoscopy or anything else for your whole career, then you go through the 1, 2, 3, and 400 level courses, and they're taught by peers. Like I'll teach the 400 level course, so you do different things like that, but you're usually taught by your peers.
Okay. Yeah, actually, in our society, we need this certificate from the company. And if we want to perform some advanced procedures like weapons or major hepatectomy, in the initial 3 cases of each institution, we have to invite the proctors. And after we successfully finish the initial 3 cases, we can perform by ourselves. Yes.
If you have the role of the proctor, so do you have the salary from the company or the institution?
From the hospital.
From the hospital.
From hospital. Company never pays.
Invitation hospital paid.
Yes. Okay. And it depends on each hospital's policies. Some hospitals pays much. It's for very good restaurant. Yes, very good dinner in the restaurant.
So in the United States,
so we can spend almost one night.
In the United States, the company will pay for Canada and the United States. The company will pay for the proctors to come in. Insurance? No, so
intuitive.
Intuitive will. So it's very specific. So, like for example, when next week I'm going to Montreal to proctor a case. So Intuitive will pay for my flight. They'll pay for the hotel, but I can't do anything on the robot because I'm not credentialed to that hospital. I can draw on the screen, but that's it. So if there's a complication or something that happens and it needs to open or something else needs to be done, I can't do anything to the patient. All I can do is advised. Yeah. So, but when I have other physicians within my own institution that I'm proctoring, then I can step in because I'm credentialed at my own hospital. So yeah, whenever I go to another center, I can't do anything. I can just advise.
Just monitor,
talk about
just
it.
give them some advice.
Exactly. That's the goal, is to give them advice through it. So we'll meet up, for example, I'll meet with them rather the week before or a couple of days before. We'll go over the CT scan, we'll go over approaches, whatever it may be, and we'll talk about it. We'll do that usually via like a web video visit and review. And then when we go in person, we review it again that morning and then do the case. And again, I stay till the job's done. So whether that's, sometimes it's somebody learning and we're just doing cholecystectomies and that's it. They have 3 of them lined up and we do them all. Other times it's, like you said, like a right hepatectomy or a Whipple procedure, and then, I'm there the whole day.
So after your proctorship of one hospital, sometimes you judge the feasibility of each groups for
Yes.
a certain procedure.
So with that, the hospital doesn't have a say in that. Some hospitals require me to fill out paperwork. Other hospitals don't, and they just want me to be there for one time. And a couple times I'll go back a second time, for example, if they want me to go back like that.
Okay, it's very unique, very interesting, very different from our society. Every time we attend as a proctor, every time we get into the console or sometimes to the patient assistant, I do some assistant work, because without our assistant, it takes a very long time. It's not good for patients. So in my opinion, at most we have to finish within 10 hours, even in the first case of Whipples. Yeah. So to adjust the time, make it shorter, I sometimes do as a consult surgeons. Yeah.
Yeah, absolutely. I mean, that's, when you're learning Whipples, we kind of talked about a little bit before, it's very difficult because there's no case quite like it, and so whether you're learning by doing distal gastrectomies or even, distal pancreatectomies, it's difficult because no other case has the same amount of dissection and then, suturing needed for a Whipple. So it's very unique. So I agree with you. I think the key when people start to try to take on these types of complex cases is to have already a very solid foundation underneath, such that, if you're taking, 10 hours plus to do a robotic Whipple, maybe you need to work on the skill set a little bit more in other procedures, because, you could probably do that case open in 4 hours. So it doesn't make a lot of sense to take over double the time, and so, it's a challenge. I'm sorry, say one more time. Oh, online, yes. So again, I'm not trying to sell anything for the company here, but so on the DV5, for example, the new device that's out and available, that has a feature where it's called telepresence, where, say for example, somebody's doing a case on that, they can send me a link. I can click into it and I'll see this. I see everything they see.
By your smartphone. You can
on a computer or on a TV screen, however I have it set up. The other component of it is that there's also, for that to happen, there's also a camera in the room like this that I can see how people are moving around. So I get 2 views. I get the operative view and I get that other view. And in that case, I've done a couple proctoring sessions where you remote in and I just sit there and watch the case and comment on it and stuff. The only downside is I can't like this, I can't draw on the screen. So when you're there in person, you can draw on the screen. So hopefully that capability will happen soon, because the telepresence makes it very nice. There's other opportunities, in the future, and I haven't done this myself, but where somebody, like you were saying, is maybe has done 2 or 3 robotic Whipples, and maybe they're trying to take on another case now, and they get stuck at one point, and then, like for me personally, if I've reached out and commented with them and worked with them, they can just call me and I can hop on and kind of maybe help guide them through that part, and then move on. So I think there's a lot coming in the future in terms of these capabilities. So I think it's going to be really helpful for the safe adoption of this technology.
Thank you.
This is the point I want to make some question, because the DV5 is very useful, especially in some recent IT technology involved in the new system. So they can record all kind of the procedure if they want. So they want to make a AI-based robotic surgical, automatic surgical system. So how's about the progress of the AI-based robotic automatic
surgery in United States because in China is also very have advanced image technology based some IT technology to make AI based some automation. So, however, in China they can use the image by themselves if they want without any license. So how's about the situation in America to make that kind of the automated or robotic system surgery? Is it ongoing?
So the most where that's happened the most in the United States is at Johns Hopkins, where they actually published a paper, I think it was earlier this year, in Scientific Reports, where that showed a cholecystectomy that was done partially autonomously. So that's independent of any other company. That's their own institution creating that ability, and what that did, it wasn't the whole cholecystectomy, it was the clipping and cutting of the cystic duct and cystic artery in a porcine model. The other, so
it's inhuman.
No, pig.
Pig.
It was a pig model. Yeah, not human. No.
Yeah,
Definitely
not yet.
not. So they are, but that was voice command. So that was telling a system, hey, do this, and the system did it on its own. There was no human actually doing anything in the case. So that's the farthest we've gotten, at least in the United States. As far as, and I'm not here to comment, I don't know, but as far as the company with access to videos, that I don't know about, that I don't hear about. In China, where I've seen something in China came out, it was earlier this year as well. They published a paper in urology where they did telesurgery. So they had, this is in prostatectomy, they had about 80 patients, they randomized them 40 and 40, where one group, the surgery was done like this, like at the center, with the patient in the same room, so on and so forth, and the other 40 patients, it was done at 3 other centers, one of 3 other centers across the country, with the farthest center being 3,000 kilometers away. And they looked at outcomes there in terms of lag and everything like that. So although autonomous surgery is starting to happen, I think we're a very long way from that. I think it's very similar to like self-driving cars. The technology's been there a long time, but it's still not a complete thing, although it's starting to happen now, but the technology's been there 20 years. I think the technology in humans for having a machine operate will have to be so safe, and we're a long way from that. I think the next big step in technological surgery is in telesurgery, where we're going to be operating at a distance. Because in the United States, they've done a case, same thing in urology, where they operated on a patient in Africa. And the first case done was from New York to Paris, and that was done in 2001. So again, the technology's been there, but I think that's where the big next step is going to be in telesurgery. I think it's going to be a long time, before machines are operating on us completely.
Okay.
There's a company in Hong Kong. They have conducted distance surgery, telesurgery, for more than 280 patients. The surgeon
already.
The surgeon in Hong Kong or in China and perform operation in Turkey or Africa. They plan to push this work. However, they also have faced some difficulty in the policy of the government. Because every government don't allow his people receive operation by other country surgeon. So they face the major problem is
legal problem. Yeah, I think so.
There's a question just about we discussed before lunch. He say, maybe can we dissecting on the nerve process and getting on to the advantage of superior mesenteric artery? What is X-ray finding of IPDA? If you dissect the nerve process along the advantage of the SMA.
No.
So can you did X-ray finding of IPDA during the last dissection?
Oh yes. Of course, even if you don't dissect the nerve plexus along the SMA, you can usually find the origin of IPDA if we found the precise outermost layer of the SMA. And another point is the direction of the view. If you see the SMA tangential from caudal side, it is very difficult to find the origin of IPDA because it comes from the behind of the SMA. So if you want to see the origin of IPDA, you have to switch the direction camera from right side or left to lateral side. Yeah.
The question is about the gallbladder dissection. He asked about gallbladder cholecystectomy. He asked why not the gall cholecystectomy with the CBD at the same time. Why the cholecystectomy was separate from the CBD resection?
Oh, it depends on the tumor locations. Yeah. It can be separated in a pancreas head cancer or belly lower biliary cancer. But if the tumor is located in the middle of a bile duct, we should resect the gallbladder and the proximal bile duct en bloc. That would be make sense. Yeah.
In our hospital, I also ask my student must be resect at the same time and broccoli.
Mm-hmm.
Yeah.
In every case?
Yeah.
Okay.
Dr. Chang?
For the bile duct cancer, it is important to reduce the risk of any cutting of the tumors. Angular resection of the bile duct with the gallbladder is necessary. However, for the case of the periampullary cancer and the distal CBD cancer, we don't need to worry about that. So we can do the two-step approach or the one-step angular resection is possible regardless of the type of surgery. So I think as Professor Wang said, cholecystectomy is a very educational procedure. So that's the reason why they give the chance to their resident and fellow to do some kind of procedure. That's the main reason.
Based on education. Okay.
Patient has cholangiocarcinoma, I will cut more proximal. I think its cutting lines are larger, somewhat distal.
In middle CBDCA?
Yes, if they assume this patient is bile duct cancer, in my case, I will cut more proximal.
Yeah.
Yeah.
In mid CBDCA, I also will done even gallbladder with the CBD and we will higher because we need a
maybe in front of right hepatic artery. In the area pancreas head cancer or uncinate cancer, this position is acceptable. Yes, for me. What is your opinion?
When I was a resident, I was scolded by the transect the bile duct below the cystic artery. The angular section was very stressed by our professor. But when we analyzed the data on the bile duct cancer, because in East Asia, including Korea, has a higher incidence of the bile duct cancer, no worry about the local recurrence, regardless of the position of transection line. So if we get the arterial resection, which means that there is enough the upper side extension, if the arterial resection is possible, regardless of the transection location, if you get the arterial resection, no worry about the recurrence. Yeah. So currently, except the Klatskin tumor or the mid bile duct cancer, I transect nearly just below the side of the liver parenchyma side around the hilum area. But except that, we can make a transection of the bile duct according to tumor location and extent of the disease progression. So you don't need the transection line and the upper part of the hilum so routinely.
And you submit the frozen section of the bile duct sample,
of course,
and confirm the negative.
Yeah.
Okay.
I have a reason why I performed the Whipple en bloc with cholecystectomy because the CHD, the blood supply of the CHD is from the intrahepatic artery diffuse duct. And the margin is just in the cholecystic duct insert into the CBD. So if you perform cholecystectomy first, maybe you retain longer CHD, even on some part of the CHD. And that will develop ischemia stricture after the operation. So I routinely use the cholecystectomy with the CBD transaction.
Okay.
This patient has ERBD, but in this case, pancreatic cancer, no problem. But in case of bile duct cancer, how do you manage the ERBD? Actually, there's a risk of bile leakage from this removed site. How do you manage it? I'd like to ask each surgeon, how do you manage bile leakage in case of the ERBD placement?
Any comments from?
I sometimes apply the GIA in the case.
Oh.
Yeah.
And the cut together with the... Okay. So you want to minimize the spill out of bile juice.
Yeah.
Okay.
In case of bile duct cancer.
Yeah, I use the same approach for the bile duct cancer. I use the GIA and then prevent the bile leak. And then we remove the upper side of stapler to get the margin checked. That is a very useful tip. Another tip is to make a double ligation of bile duct. So one ligation, but it is not complete. So after make a small the penetration to remove the ERBD, and then we make a double ligation after that to make to prevent any kind of spillage.
Yeah. So while we retract ERBD, some is a tissue will come out from this bile duct.
So in case of the long stent, we input the stent into the duodenal side, and we don't need to extract the bile duct.
Is there any comment from Professor
Professor
Ilona? Same. Okay.
Professor Su, how about your opinion about the separate cholecystectomy from the CBD transaction? Professor Su, no, 苏正熙苏教授。好了，苏炳瑞，你说啊。
Cholecystectomy, when do the hip operation, we usually do the en bloc resection followed by Professor Shen's opinion. We translate at a CHD common hepatitis level.
So how about IPMN? You still transact at the proximal area, okay? Yeah, it's your routine.
If you make a high ligation, high transection of the bile duct, it make tension around the hepaticoduodenectomy, especially for the small bile duct. So in case of the IPMN, without the obstruction of the head, it make very difficult and make high tension, followed by the stricture of the anastomosis or the leakage. So the routine transection above the hilum area is not so helpful in some cases. So we must be very cautious to decide the transection line.
Yeah, I agree with it. In IPMN case, I mean the non-invasive tumor, but some suspicious HRS or worrisome features, we divide the common bile duct very parallel to the GDAs. Yes, we dissect and expose the CHA, and we ligate the GDA, and we do not go proximal, just parallel. So we ligate and cut the common bile duct just on the pancreas, because we don't need any oncologic lymph node dissection in such early stage cases. I call it the level 1 dissections. Okay, finally, the specimen is completely extracted or brought together. Professor Wang is here. Anyone who can make a comment about the timing of a specimen output? Do you extract?
Extracting, yeah, we will be extracting now. Because we need to send the margins. Today, yeah, everything is in the specimen, so we'll quickly extract. And then so we can send the margins. OK.
Is that common timing around here? One of the things we'll do, particularly if I'm worried about the pancreas margin, is when I transect the pancreas, that's when I send the pancreas margin, because now you kind of have to wait right before you do the PJ. So, I mean, that's for us, it takes about a half hour, 40 minutes for the frozen to come back. So if I ever... Yeah, so I transect the pancreas, and then I send the margin there, and then I finish my dissection, because then by the time I'm ready for the PJ, I already know if I need to take more or not. Same type of thing for the bile duct matters less, just because I do the PJ before I do the bile ducts. But the PJs, I get that margin early.
May I have a question? Is how long does it take to get frozen biopsy result in your institution?
40 minutes.
40 minutes.
40 minutes.
40 minutes. Yeah. For that is transaction. At the time transaction is frozen biopsy is better.
Yes, that will be more reasonable.
So the frozen section diagnosis is very crucial for the bile duct margin, and then according to the margin status, we must decide the further resection or not. So for the case of the CBD cancer, we transect the bile duct first, and then submit. And then check the frozen section to the margin positive or negative. So I think the distal the treatment and then go forward to the bile duct proximal margin is sometimes needed to get the more margin for the bile duct side. However, the practical reason, the frozen margin-based surgical strategy is very useful to reduce the time and then modify the surgical strategy. So in case of the CVD cancer, I make a dissection around hepatoduodenal ligament and then transect the bile duct first. And then do another kind of the procedure.
So you mean at the first section? Yeah, before cutting the stomach.
Yeah, after make a fully cocalization, I make the dissection of the lymph node 8 or the 9 and 12, and then transect the bile duct and then check it.
So really first stage. Okay.
So the when bile duct cancer case, we also cut the bile duct as soon as possible. But another one of the issues is so that if the cholangitis, preoperative cholangitis occurred, so actually after the cramp before the resection, so sometimes cholangitis after the surgery is more.
Severe.
So that is a dependent resection time, I think. So after cramp, the bile duct probably, so it's better to remove the.
Yeah, we need some declamp intermediate. Okay. I really agree with it. And I want to ask you, what is the pathway of the afferent limb? The elevated jejunum. What is your pathway? I use the hole in the mesotransverse colon, which was originally the duodenum was attached. That would be the most stable phase, but maybe they use the original TRIDES pathway, the duodenal pathway.
Only the previous study showed that the kind of is pancreaticoduodenectomy through this the previous duodenal side, the increased risk of delayed gastric emptying. You don't any experience about?
Why? What is the reason?
Sometimes a congestion.
Congestion.
Yeah, this bowel passage sometimes problem.
Okay.
Okay, so you mean the obstruction of elevated jejunum, not but
I do
DZE.
this make you opening
Mhm.
mesocolon. Yeah. Not through this original site of duodenum.
Okay, okay.
Several years ago, my friend Amsterdam group visit our center. We discussed about that kind of problem. So initial period, the senior professor performed the pancreaticoduodenectomy using the trigeminal ligament hole. However, the vein, especially vein and artery, is the king because the rotation of the jejunum to the trigeminal ligament side make a very the stop
Strong
the
twisting.
angle, make some congestion or the bowel ischemia and so on. So we changed the route in the trans mesocolon side. Is very natural and no congestion of the vein, no bowel congestion. That is very important to reduce the delayed gastric emptying. So after the changing of that kind of procedures, our hospital's delayed gastric emptying, especially for the robot surgery, is less than the 5%. Very reasonable.
Very good.
Yeah, so the most of the patient can start the diet POD 1 day or 2 days without the delayed gastric emptying. So currently the delayed gastric emptying rate is around 8% in our hospital. So that is very useful rather than use the previous trigeminal ligament.
Okay. What is your opinion?
Yes, we do use the trites hole and come through that. And I agree, there's two ways to kind of pull it through, and it depends on kind of how it lays, certainly. The only thing I worry about when we bring it through is it depends on how much of the pancreas, because sometimes that can be a challenge if you do an extended Whipple, where you have to then come through and then come over the vessel, because then it actually gets a little heavy and can compress on the SMV and portal vein a little bit. So in that situation, we'll make the traditional mesocolon hole and come up through that, so you don't have the compression. But I understand the concern as far as the vessel twisting and things like that. But I think there's a way to be able to bring it through where it doesn't have that. And we do say that we don't do pylorus preserving. We do almost all of them as kind of more of a classic approach. When we do all of ours, and then we do a stapled GJ and then close the commonotomy is how we do ours on the distal side. So like you said, it's not, I know some people do all of them on the right side, all the anastomoses. And we do our PJ, our HJ, and then our GJ on the opposite side. And we have like I said, we feed on day 1, day 2. So.
Another concern is when there is a recurrence, local recurrence. In case of Uncinate cancer, sometimes it's a local tumor can involve.
Yeah.
There is an upfront loop.
Yeah. Okay.
I have seen, actually, I remember I seen a case from another hospital. They use the loop through the tracheal. It caused local recurrence, and finally it was the bowel was obstructed by the tumor. So personally, in pancreatic cancer, I don't favor through the duodenal route.
Okay.
It should be away from the duodenal route. Use the mesocolon, mesocolon. Yeah.
Dr. Hewitt, you said that you use the GIA for making a duodenal jejunostomy. So do you make a gastrojejunostomy or the duodenal jejunostomy using the GIA?
To make a gastrojejunostomy. So when we pull it through, I'll make a vertical, so it's an anticolic, retrogastric, vertical gastrojejunostomy, where the afferent or the HPB part limb will be more proximal on the stomach, and then it'll be vertical down where the efferent limb is headed down. So the natural pathway of food as it goes down into the stomach is going to be down to the efferent limb and out. So I fire a stapler up like that, kind of make a vertical gastrotomy that way, connect it, and then close the commonotomy in 2 layers.
If you do the GIA anastomosis, that is I think that is no merit of the PPPD because you don't use the pylorus. Yeah, that is a gastrojejunostomy, not the duodenal jejunostomy.
We transect the pylorus goes with the specimen, so we almost always do a classic Whipple in that sense. Yeah, more classical. Yeah, yeah. Otherwise, like I said, no, we don't do PPPD. I've done a couple of them in certain benign diseases. And my Charles Yo, who was my trainee in residency, or my attending in residency, is a big proponent of the PPPD, doing hand-sewn DJs. And I've done that robotically a time or two, but I just think it's much cleaner, much more consistent anastomosis. Plus, by that time, I'm pretty tired in the case, so I think it's a lot faster to do a GJ, and we have pretty good outcomes with that.
In our institution, is my junior doing pure robotic. She do this gastrojejunostomy, even for the part of preserving pancreaticoduodenectomy. But the tip is that she doesn't do GJ on antrum. Antrum is worth too thick, so this he do the gastrojejunostomy the body side, yeah, side to side.
She preserved the pylorus. Okay. Oh, it's very, very interesting.
I think that is not natural. So if you make anastomosis at the body, I think some of the food is reserved at the entrance side. That make some problem, I think.
I thought that it concerned, but no problem.
There is no
yeah.
Okay.
In her
no disease.
experience, no experience, no delayed gastric emptying.
Oh.
Not related with the delayed gastric emptying. We talk about the food. The emptying is the very delayed, because the patient has no symptom related with the delayed gastric emptying, but many of the food that remain in the stomach. Yeah. So that will make some the problem in the long-term period.
Yeah.
So that's the reason why I ask about the.
In 2006, I published a paper, used the scintigraphy to study the delegation in PPPD and standard PD. We found standard PD patient no symptom of delayed gastric emptying, but if you use the scintigraphy, you can see most of the food retain in the stomach. So just like Professor Jiang said, no symptom, but more food will retain in the stomach. But yeah, but in standard PD, they have long-term side effect is marginal ulcer. Marginal ulcer.
Marginal ulcer means anastomotic site?
Yeah.
Oh, okay. Mm. So do you prescribe the PPI for every WIPO patient? Non routine.
Medical insurance are covered, but one paper after PPI use in PD patient, the symptom and the lifespan will increase.
Oh, what's
after the PPI in PD patient, the quality of life and the long-term survival will
improve
yes.
with PPI.
Yeah.
Oh, it's
the
very
paper is
encouraging.
published about 20 years ago.
Yeah, 20 years ago. Yeah, in our routine practice, we prescribe the PPI to all WIPO patients for their lifelong time, because we experienced several cases of peptic ulcer perforation and emergent operation in a patient who decided by themselves to stop the PPI. Actually not. So we used another disease definition. The reflux esophagus. This patient has a reflux esophagus, so I need.
In Taiwan, major operation can use PPI. Yeah.
It's a safer.
Yeah, same. Ours is approved. We give everyone.
I only do the lifelong time, the prescription of the PPI in the cases with the history of the gastric ulcer, marginal ulcer.
Okay. So you recommend the patient to undergo the upper GI endoscopy routinely after WEPO? So now they're ready for PJ, I think. Are they waiting for? Oh, yeah. So we can have a break.
I have one question.
Okay, please.
Okay. Robotic view
Yeah.
is great, but narrow, very narrow. So
So-
when you bring up the jejunal
Mm.
limb through
Zoom
the mesocolon, could you tell me the tips to prevent twisting the jejunal?
Yes,
when
yes.
bring up the
Sometimes we anastomose and we
I'm
notice
afraid
that the
of it.
elevated jejunum is twisted more than 180. Yes.
上镜了。
Oh, this is the specimen.
S-
Oh, it looks like a pancreatic cancer,
So
right?
we can to quickly, I'll allow Dr. Chen to explain the specimen while we wait for the defrosting of our T cell. Okay.
I think the mucosa of lumen of the bile duct looks smooth, right?
Yes. Very smooth.
Yeah, so I agree with
the digital CVD over
Yeah.
here, and this is a
This is the main
pancreatic.
tumor.
Yes, a main tumor. The size about 2.5 by 2 centimeter. Yes. The margin quite seems good. Yeah. And we will send the margin for the frozen section. Okay.
Okay. So you will start the reconstruction after confirming the negative margin.
Yes.
Yes, sure.
We will wait, right?
No, we will do some wrapping around the GDA.
Okay.
And yeah, and as you can see, I was trying to check the mesopancreas dissection around the SMV and SMA for any possible bleeding thereafter. So before we extract the specimen out, we usually do what Dr. Hu was saying that during the transection of the pancreas neck, we will also take the margin so that we don't need to wait. But usually after the part of extracting the specimen, our pathologists are pretty quick. Maybe after sending the specimen to them, we can get the answer within 15 to 20 minutes, unless there's a OR specimen checking traffic. Yeah, but we usually, yes, we have a very good supportive pathologist. So we forgot to defrost the T cell. So now we are waiting for the T cell to be more liquefied so that we can spray it out on the SMV and SMA today.
Okay.
It's also not routine, but if we do level 2 or especially level 3 dissection, we always try to reinforce the SMV, SMA area with some anti-coagulant material such as T cell. Yeah.
Thank you.
Thank you.
Okay.
So regarding your question, I think, yeah, of course, before elevating and taking up the jejunal limb, yeah, of course, we carefully check and we make the good retraction of a mesocolon cranially and make an open field and confirm several times the election. Okay. Yes.
experience in cases who received the previous right hemicolectomy and with ileo colon anastomosis, and the patient need to have a Whipple procedure. What the anastomosis order or the position where you do that.
You mean the pathway?
The patient previously received right hemicolectomy, and now the patient is receiving
previous ablation.
Yeah.
Or in such a case, we can change the pathway to the original trans ligament or middle colic area, or sometimes left side, or sometimes anticolic. Yeah, if the patient had the enough length of the mesentery. Yeah. What is your opinion? If the patient had some adhesions on the right side of the mesocolon.
We usually use anticolic approach.
Okay.
Routinely.
For HJ.
No,
HJ.
Yeah, yes.
And you use a GJ, PG,
and if we do the surgery for the congenital biliary dilatation, well, we usually use anticolic because it's easier. You don't have to make a new hole.
Yeah.
So,
but I'm wondering in a very, obese patient with a very thick mesentery, I think
in that case,
it's links.
You have to make a new hole, but you have to sacrifice some intestine, then you can bring up to
make a longer limb. Okay.
Yes, so that's why routinely use anticolic approach.
Makes sense. So they are applying some fibrin grooves to cover all the stumps. Professor Wang, don't you use any mesh together with the fibrin groove? As you know, the Korea and the Japanese society had a collaborative randomized control trial to reinforce the PJ anastomosis using a mesh and fibrin grooves. Unfortunately, the result was not negative, negative. No impact on the POPF rate. But still, the many Japanese surgeons believe in the efficacy of wrapping the PJ anastomosis. But they apply to the arterial stump, not the PJ itself.
有准备好了吗？等一下哦，他刚刚好像有问我问题，所以你们麦克风有开吗？哦 ，OK。Yes, Professor Inoue, you were asking me questions, right? Yeah, we don't use mesh to reinforce the stump of the pancreas or anastomosis. We were taught by our teachers that I think the anastomosis itself is more important than the reinforcement of these biomaterials. So for the stump and anastomosis, we actually do not use any kind of mesh.
Okay.
Yeah, please come in. And this is a T cell we want to reinforce on the mesopancreas dissection of the SMA and SMV. So we can start, please. Yeah. Okay.
Is this a fibrin groove?
right?
Cell. Yeah. Mm-hmm. 慢一点哦，这里。Yeah, and then all the area that where we have performed the lymph node dissection, so also around the GDA. 剩多少 ？OK 好。And then the rest 压下纱布 goes to the IVC area.
Yeah.
Yeah. 把它喷完。
You use
Finish.
the very plenty amount of grease.
Yes.
I think it's
Anybody?
really
This is a
expensive,
10.
is it?
The price is actually not so compared to compared because the company usually they have 4 cc. So in the
4
earlier
cc.
days we use 2 4 cc syringe,
Okay.
and then they come out with a 10 cc syringe, 10 cc, and
10
the
cc.
price
You
is
use
actually
10
yeah.
cc. Okay.
This is 10, yeah. It's actually cheaper.
Okay. Okay.
The 10 cc, yeah. So we decided that we can use the 10 cc. Yeah. Okay. Remove. 3个 proline.
So Professor Wang, we have discussed about the pathway of the jejunal limb. So is there any, policy about your pathway of the jejunal limb for reconstructions? Most of us prefer the transmesochoric pathway.
Yes, we always do a mesocolon window. So it's a retrocolic pathway.
Okay.
你换，赶快换呢。They are out of CO2, so they need to change before everything collapses. You guys can still hear me? Can anybody still hear me? 哎，我现在是 on 还是 off？ 请问讲话他们听得到还听不到？哦 ，OK。那我怎么听不到他们？
What is he talking about?
Oh, okay. Can you guys hear me?
Yes.
Oh, okay. We usually do the retrocolic route for the pancreaticoduodenectomy, and most of the time we can use the right side.
Okay.
Yeah, depends on also the stump. If sometimes if you do a more extensive Whipple, maybe wasa over the splenic artery, and the pancreas stump is too far to the left of the patient side, then we will consider the left side of the mesocolon window.
So in such a case, the order of the reconstruction side will be changed.
No.
Like so-called not the child, but like a Whipples, HJ, PJ, and DJ.
No. Okay. We never change the order of
child.
always pancreas anastomosis first.
Okay.
Yes. So this is the part where we are just trying to do the wrapping procedure for the GDS stump.
Professor Shin Wang. I have some question. Can you hear me?
这边 traction， 打开我的麦克风。Yes, I can hear you.
Yeah.
It's Professor Chen, right?
Yeah. The wrapping, using the parchment ligament, the useful tip to prevent the POP-related pseudoaneurysm bleeding. But in case with the pancreatic cancer involving hepatic artery, so sometimes the tumor recur around the hepatic artery. So if you wrap the hepatic artery using the parchment ligament, I think that some of the cases with the recurrent around the ciliasis hepatic artery is very difficult to differentiate with the tumor recurrence and then the parchment ligament itself. How do you about the experience of that kind of the cases?
So you mean if there is a recurrence around the hepatic artery area? If we wrap the falciform ligament, it will be difficult to see from the image. This is a difficult question, I think, to answer. But it's not so often that we see many or a lot of recurrence around the proper hepatic artery area, actually. And I think if it really does show recurrence, sometimes with a follow-up, serial follow-up of the CT scan, you will still see some difference. In the earlier days when we started to do the wrapping, we often get our radiologist report saying there's a soft tissue on the CT scan around the common and proper hepatic artery. That is because we are wrapping the entire common and proper. So at the earlier time when we do this wrapping procedure and we see their report, they often, I think it's like a false positive comment on the CT scan. We need to talk to them. We have to tell them that please have a look again. That's usually the soft tissue that we are wrapping. And then over the years, our radiologists understands more of our surgical approaches. So now we see less reports commenting on the soft tissue area. But if there is still recurrence, I think after every 3 months we scan our patients. You can still see the difference on the image. But honestly, I think maybe my limited experience, we don't really see much difficulty for them to tell us whether there's any recurrence on this area. Yeah.
If you find growing soft tissue density, it indicates the recurrence.
Yes,
but
and sometimes we can
itself will not change.
Yes.
Yeah,
And sometimes you can also use, if we suspect any kind of a soft tissue and it's difficult to differentiate, they would recommend us to do MRI maybe, and then we can try to differentiate then.
Yeah.
Yeah.
Regarding this issue, I would like to make some comment.
Yeah.
And by CT scan, usually the fat looks more low density. It's very easy to tell the difference between the recurrence and the fatty tissue. Besides, as Professor Wang said, we follow up CT scan every 3 months. So it is a new lesion. That means it could be recurrence.
And of course, we can check the tumor markers.
Yes, yes. So this type of practice, I think, do not make any difficult for the tumor recurrence follow-up.
So is it a time to place the drain behind the anastomosis, right?
Yeah, microphone on. Yeah, this is the time where we like to preset our drain in place. So this is the number 2 drain. Usually our number 2 drain goes behind the pancreas anastomosis. Yeah. Below, actually, sorry, below the PJ, and then let's find it.
Okay.
Yeah, this is the number 1. Oh, okay. It's actually vice versa. Let me just change again. This one is number 2.
What is the type of drain do you use?
This is a Jackson Pratt.
Jackson? J-Buck.
Jackson Pratt.
JP. J-Buck. JB. Okay.
JP.
To avoid difficult placement with the robotic system has been docked.
Okay.
So we pre-placed the drain before docking. It's easier to do that.
Yeah, especially behind anastomosis. Yeah, I agree with that. I insert the drain into Windsor's foramen just after resection, and we insert the post PJ drain just after Brungard posterior sutures. I mean, during anastomosis. What is your opinion? You insert afterward. You can do it. You don't insert. Okay.
Maryland. No.
This is a preset of drains.
Microphone is still on. Microphone on 吗？开的 ，OK. It's okay. Remove the gauze, please.
Another question is asked about the length and the kind of the PJ stent.
Okay, the length. Usually we place the stent and we measure how far it goes into the remnant of the pancreas. And then we leave maybe 0.5. Just please hold the jejunum. Okay. Okay. Above the drain. Going. Go. Okay. Me just finish up. Okay. Thank you. 纱布，不用拉，没关系。纱布。I think for the stent of the pancreatic, you either leave longer or or short, fairly short. So our team prefer a short stent that's sticking into the jejunum. So like I said, we usually place the stent and measure how far it goes, and then we leave just maybe 0.5 centimeter out of
pancreas.
Yes, right, out of the pancreas duct. Yes.
We have some concern about the stent
go into the pancreas after operation.
Yes. Yeah, that's
You have
also
some
a
cases
concern.
with the loss of stent in the remnant pancreas.
We only had one, I think, if I remember correctly.
Only one.
But Professor Shi maybe can comment for us. We had one. Unfortunately, it was a little bit too, it went in a little bit too long. That's why when I was placing this stent, I was checking how far it was going. And
as far as possible.
Okay.
Yeah.
Yeah, just
we check and then we cut.
Now I understand. So this loss stent will not go deeper.
Go deeper
Yeah.
as much
You
as
not
possible.
go deeper.
Because we have one case, the stent go completely inside
Yeah,
the pancreas,
yes.
and we cannot reach the stent.
Mhm.
We just leave it alone. But it's okay for that case.
Yes. I have two cases,
Two
the
cases.
similar case.
And
And the professor, you also mentioned. Yeah.
Needle driver, please.
And do you have any complication after that?
Unfortunately, no.
No.
But the Professor Yun said that it has some.
I insert a short stent, 5 centimeter, but sometimes the stent migrated into this distal pancreas, sometimes into intrahepatic duct. There's a stone.
Stones.
Yeah, it causes stone. Notice I tried to not insert the stent if the bile duct is not.
Okay.
We have some case, Dr. Lee.
All
Can you
pulling the
show
stump.
your study?
All pulling the stump.
Explain your study.
是带一点点线头的。
And I have recalled about 500 PD cases in our hospital, and we have experienced 3 cases with distal migration into the distal end of PDAT. And maybe 2 or 3 of cases have residual PDAT stone.
PDAT stone.
Yes, and the recurrence of pancreatitis. And also, in my opinion, maybe we should not leave this stent too short because the migration.
Okay.
And I have experienced the pancreas stent penetrated the upside side of the small bowel, and need to repair.
Yeah. I hear that the TBGH group had one case is with the perforation of the jejunum because of the continuous contact of the loss of stents.
Because in our hospital, we usually use the suction tube as the PDAC stent. So
suction tube.
Yeah, suction tube, about 6 French or 8 French. So after operation, I think the suction stent is very hard. So maybe will induce some penetration. And we also have the 3 other cases of migration into the HJ. And it also induce the recurrence cholangitis and need to perform the ERCP to remove the tube. Yes. So maybe I agree with Professor Wang not to maybe you can a little bit longer than our expect.
Than its capacity.
Yeah.
Okay.
And
Makes
when we
sense.
do the PG anastomosis, I will have to prevent the stent directly stick on the upside of the jejunum. Yeah, to
But
prevent
so,
the penetration.
By your method, most of patients have their lost stent lost.
Yes.
Afterward.
About around 30% of cases would have a stent migration within 3 months. Yeah, when we perform the CT scan during the follow-up.
You mean migration means a drop off?
Yeah, drop.
Okay.
Maybe from the pass out of the with the feces or to other anastomosis.
This is another discussion point, how we can make a very precise small hole on the jejunum.
Yeah, one thing I think is nice, I don't know if what you guys call it. We call it a Colorado tip, like on the bovie. So there's something called a Colorado tip. It's a very, very fine tip. It's used a lot for thyroid surgery and things like that, where the bovie tip is very, very sharp at the end. And so it's about that long. And you can introduce that and you can just kind of basically the top is metal that goes into the bovie. And then the end is a very, very fine, it looks like a pin, like it's very sharp. You can make the small enterotomy that way too. Otherwise, I've seen it done like this. But yeah,
it's done by assistant.
Yes, well, it's brought into the abdomen with the assistant. Yeah, and then it's used by the surgeon. So what you'll do is you'll grab it in the middle, you'll put it exactly where you want, and then you'll take a monopolar device and burn the top of it, and it conducts down into the bowel. But so I might have missed this. I was just hearing the comment on stents and everything like that. And I think it's always a great topic. There was a study recently published in Annals of Surgical Oncology by I believe it was MGH, that they published their series on external stents and robotically. So they did in basically using the pancreatic fistula risk score. They stratified patients, and patients that were deemed the most high risk, they gave them all external stents, and they had mostly any leak that they had one grade B POPF, and then they had a couple grade A's that's it, but zero grade C's.
Excellent.
Yeah, and I think it was maybe about
they
40 or 50
advocate
external stents. Yeah, exactly. And that's, to my knowledge, that's the only thing I've seen that has been able to decrease the POPF or symptomatic POPF rate. And so we're going to start to do that at our. We haven't done it yet. I've done a couple during training. I did a couple of those, but I think it's a really nice skill set to have to do an external drain. So what they would do is it would be usually like a pediatric feeding tube, something like 8 French or 6 French, and then you'd make a second hole in the limb, maybe about 2 or 3 centimeters from where you make your PJ hole, and then you externalize it that way. And then you would basically follow that up, and if there's no leak, then you can cap it, and then you can study it in 4 weeks and then pull it out if there's no leak.
Can I make a comment on the issue of the stent? Over the 10 years ago, we performed a randomized control trial comparing the external stent and the internal stent. So basically the prevention of the POPF is similar, but in case of the external stent, we need a very long stent. So during the pulling out the stent, it makes some problem. Also, sometimes it kinked and obstructed the pancreatic duct related to the pancreatitis and so on. So overall complication related with the anastomosis is higher in external stent. So so from that time, we abandoned the external stent and used the internal stent. However, regarding the length of the stent, somebody used the long stent and somebody preferred the short stent. In our group, currently I use only the 3 centimeter short stent because even if you use the very soft elastic too, after the 3 months or the 6 months, it converts into the very thick and strong wire-like the stiffness we can see. So it has a higher chance of the penetration of jejunum if it resides in the bowel. So sometimes in migrating the pancreas distal part, and then also into the hepaticoduodenostomy, make a stone or cholangitis itself. So every stent, short or long or extended stent, has a peculiar complication related with that. So seeing over the 6,000 cases of the WIPO, so we experience the whole kind of the stent-related problem. But if we use the long stent, I think it makes some more the dangerous problem, like the penetration of the bowel related to the peritonitis. So currently we use the short stent to reduce the risk related with the stent.
Fatal complication.
Use the bronchial method to perform the pancreaticoduodenectomy. You use bronchial?
Modified bronchial.
So all Have you used Blanca?
I've changed over time. When in training, I did a modified blood guard that we used silks for the outer layer. But now, since I've been doing them, as an attending, what we'll do is we'll use a barbed suture.
Barbed suture.
Barbed suture.
Continuous.
And we'll run a continuous layer. Yeah, one coming from the posterior side. Then we'll do the inner layer interrupted with 5-0 PDS. And then we'll do the anterior second layer to close it off and tie them both there.
No, actually, most of the surgery use the Blanca tracheostomy now.
But sometimes we feel stressed because after penetrating the full layer of the pancreas, we encounter the arterial bleeding.
Yeah.
I hope she doesn't suffer. But sometimes, maybe one of 3 cases, we suffers arterial bleeding. She confirms not penetrating the stent. Operation. It's acceptable. It's acceptable. But still have some small bleeding. I think it's not so, comfortable for surgeons. So, yes, she applied some compressions to control. Is there any tips to prevent this kind of small bleeding? No. In my experience, I inspect the posterior side of the pancreas, and if we find a small arterial branch on the surface of the pancreas, I make sutures and close it. And I think it's really effective or not. Just after I penetrating the full layer, just before I remove the needles, I apply the monopolar soft coagulation on the needle. Through the needle, I coagulate the pancreas parenchyma with the soft coagulation. It's a kind of, おまじない。おまじないってなんて言うんだろう。
I think in the posterior side, we can make sometimes another suture using the 5 or 6 0 Prolen. However, in case of the anterior side sutures, after the Brungat and make anterior suture and the compression suture itself, usually the breathing is stopped.
Okay. Of course, after confirming the Brungat knot, it's okay.
That's why I kind of like using the continuous with a barbed suture, because I just pull it tight and then it ends up, hemostasing.
No bleeding.
Yeah, because even if you do get into the vessel, the vast majority of these vessels are quite tiny. So if you pull and then compression, it almost always stops.
Stabilizing of the pancreas parenchyma using body suture. So because some body suture.
Yeah, as far as tearing it or anything like that, so in a really soft gland, I'll sometimes use 4-0 barbed instead of 3-0 because it just ends up being a lot softer. And then the challenge that can happen is certainly, you can be too rough with it and tear it. But I think, as far as using that suture, I try to, what I'll do is use my other instrument to push up the bowel such that there's very little tension on it. And then what I found is when you run a continuous layer, it actually disperses the tension over each of those sutures, so you don't get ultimately as much tension on that layer, I find.
摄影大哥这边，那边 speaker 讲话我会 lag， 我会听不太到。
I would like to give a question to the Japanese professor. I forgot the names, Professor Yamamoto or working at the Kinki University, invented the thread for the pancreatic anastomosis. So in this case, it's Brungat, the straightening of the curved needle, but in Japan, the surgeon invent the straight needle for the pancreatic anastomosis.
Yes. Actually, I invented.
No, you invented?
No, not me, but I invented the robotic, version of a straight.
Mhm.
Yeah, very, slight curves. Almost
slightly
straight.
curved.
Slightly curved.
Mhm.
Not completely straight. But I invented the double-tailed 15 centimeters,
Mhm.
the sutures only for Brungard. And another Japanese surgeons invented some paired
Mhm.
kit, paired set. Yes, Dr. Ishizawa,
Ishizawa?
my friend.
Mm.
Yes. And Dr. Matsumoto from Kinki
Yeah,
University
Matsumoto. Mhm.
likes to use that kind of paired, sutures.
Which is the most convenient to do the pancreatic duodenectomy?
It depends on. I want to recommend my. I can introduce the company.
There's a question. The ask a question about what's the difference between the VDOC and or proline for the outer circle of the for invagination procedure.
Invagination.
Yeah, I think this attendee they use the modified invagination procedure.
Modified invagination.
Yeah.
For robot.
Yeah, for the pancreatic duodenectomy.
Okay.
They're using the proline or VDOC.
VLOG. Invagination. I don't use it. Is there anyone who uses the invagination? It's very
The
traditional.
question is related with the Dunkin, the modified Dunkin method. Yeah.
I think modified imagination maybe Dunkin.
Yeah, I think so. But when we compare the long-term result of the anastomosis, so if you don't do the ductal mucosa anastomosis, most of the parenchyma shrink with followed by the stricture of the pancreatic duct.
Mhm.
So in the initial period, the short-term safety regarding the pancreatic fistula, there may be no difference. However, for the long-term, the patency related with the pancreatic function, ductal mucosa anastomosis is a mandatory for the maintenance of the patient quality of life related with the pancreatic exocrine function and then also the endocrine function, because after obstruction, the stricture of the pancreatic duct, it is related with the pancreas parenchyma atrophy and followed by the endocrine insufficiency. Mhm.
So Dunkin procedure have long-term side effect. Okay.
I have question for Shinny Wang. Actually, there is the straight needle. There is inserted the superior side and inferior side pancreatic duct. The suture did not include this
Include the
duct.
main pancreatic duct.
But I read some paper that is not including the P duct. Increase the risk of the
Wow.
PF.
You know such kind of interesting study.
So why the stitch does not include that does not involve the P duct?
Yeah, it's very important point.
The specific reason?
Yes, in open surgery or maybe laparoscopic surgery, we can include the main pancreatic duct. But in robotic surgery, the adjustment of the strength of tying of the including knot is sometimes difficult. So sometimes we tying too much. In such a case, it
causes the stricture of a main pancreatic duct. It was included by the U sutures. So that is why maybe the TVGH doesn't include. And I agree with that.
So
What is your opinion, Professor Shi?
Are you asking the U suture include the whole PD? We usually place one U suture above the PJ to load. But sometimes if the PD is just on the center, we use the second one to include. But in that situation, we have to place a stent. Internal stent is not our routine, except it is very small PD.
Professor Si, how do you know you did not include the P duct using U sutures?
You can see Professor Wang always put the stent after U suture near the duct to check if the U suture is go through the PD or catch the duct or any blood from the PD.
You means to pour or push the P duct stent always to ensure you do not include the P duct.
Yes. Or sometimes if there is blood, fresh blood from the duct, that means maybe the suture has gone through the duct. That's our routine. We always check that.
The stent for retraction of main pancreatic. I learned it from you.
That is a useful tip. Many centers use the same terminology of the modified Brungas technique, but initially Brungas techniques cover the pancreatic main duct. Yeah. Yes. However,
this is original.
Yeah. However, somebody used a similar procedure, and somebody used a different one like this. So we also use the modified Brungas, not covering the pancreatic main duct. So the only upper part and the lower part of the pancreas parenchyma is covered. But when we make a suture interval is very close, especially in the jejunal side, we can cover the whole the posterior pancreatic jejunostomy, the watertight anastomosis is possible without the compression of the main P duct. That is very crucial. Also, the anterior layer sutures, we can modify the number of the suture depending on the length of the pancreas. So currently, I use the modification of the modified Brungas. So usually those with the large pancreas parenchyma, it is very impossible to cover the whole parenchyma. At the times, I make the compression suture upper side and the lower side, depending on the diameter of the pancreas parenchyma side. I think the most important thing is to avoid any injury of the pancreatic duct, not make any mechanical compression. That is very crucial for the safe anastomosis and related with the long-term quality of life related pancreatic duct anastomosis.
Okay. And what is how much is your bite of a Brungas sutures? How much is the length from the stump? Do you have any criteria or any routine length from the penetrating area and the stump?
If we can cover the whole cut margin of the pancreas using just the one thread, no problem. But especially for the hard pancreas, it is usually not enough. At the time, we sometimes do another additional stitching to cover the whole pancreas parenchyma.
Okay. In my experience, I don't take not so much distance from the stump to the penetrating spot, because if the pancreas is very thick, it needs the more length of the jejunum. Yes. And after tying, it sometimes causes the stenosis of the jejunum if the pancreas stump is very thick. It's my opinion. So how much is your length? I want to ask the expert's opinion about the distance. I usually place only the 3 or 4 millimeters from the stump to the penetrating spot. Yes, yes. Very small bites. But it works. Yes, bite. Only 3 or 4 millimeters. Mm-hmm. You mean the pitch? Yeah, pitch will be up to 1.5. It depends on the width of a pancreatic stump. If we need more, I put the third usage. But as you know, the Japanese patient has a small pancreas, so usually we need only 2 pairs of usages. Professor Shi, this monofilament is a PDS50, right? Or is this a 50? 4, okay.
And then for the small duct, we use
sorry.
6.
This is a 50 proline.
50, okay.
50 PDS. Yeah, 50 PDS.
RV2?
Yeah.
RV2?
Yeah.
Okay.
Yes, because today you can see the pancreas is very, very fragile. And I'm worried about, we usually use 4 PDS, but now if I see the pancreas is very fragile, the duct is very thin, now I would consider using a 50.
Okay.
Yeah, so today, for this case, it's a 50 PDS. Yeah.
And
you were talking about the penetrating distance. You were talking about the distance of the penetrating.
What is your preference?
Because I heard you said very close, right? 3 or 4 millimeter. Did you mean? I think for us, it should almost always more than 5. Because we sometimes worry about this area ischemic change also.
Okay.
So for us, I think at least 5.
More than 5.
Yeah.
Okay.
Yeah, more than 5. And but I agree. Sometimes if you have a very thin jejunum and you have a very thick pancreas, and then that may be a little bit troublesome because then after embedding, you almost see the entire jejunum pressing against the entire stump. And you were saying that we told you before we had a stent penetrating. That's one of the case we had. I think we had 2 cases, 2 or 3 pancreatic stent protrusion. One was actually really compressing against the opposite side of the jejunum. Yeah, because of the very thick pancreas. And I had another one actually migrating to the distal part of the jejunum and eventually penetrating the jejunum. And we saw the patient with umbilical wound infection. Initially, we thought it was wound infection. And then we realized there was some intestinal fluid coming out. Yeah, then it was a penetrating stent through the jejunum, distal part of the jejunum.
May I have a question? I did think you tried to place the note outside the lumen, but I don't care whether it is stitch is located intralumen and outside the lumen. What is its advantage? Do you feel is any advantage of this outside note always good?
Yeah, we are taught never to leave the knots inside.
Even if you use absorbable sutures.
Yes, even if we use absorbable, we are always being told that we should consider placing the place the knots outside.
It's me to tell them.
Okay.
I
It's
always
your guidance.
ask them to tie outside the lumen, both for the pancreas duct and also the bile duct. We always tie outside the lumen. Inside.
Yeah. Yeah.
But for the P duct, especially the small one, tie it outside is easier to tie inside. I think so.
Okay. And do you know Kathleen Tay from Philippines? Kathleen, Professor Kathleen. She said she always used the non-absorbable monofilament or PJs. So in such a case, she have used the same method or external sutures.
For the bile duct osmosis, because we always place one layer. So I think place outside is better. It's a good idea.
Yeah. In my experience, we use, if we place the 6 knot, interrupted knot, I use only one internal knot, and otherwise we place all external. And if we use the 8 sutures on the bigger pancreatic duct, I use the 2 internal knots with the absorbable sutures. What is your preference, Professor Nagakawa, about the inside, outside?
Actually, my procedure is so that if we reconstruct the anterior side, posterior side, we usually use continuous suture.
Continuous.
Yeah, and then but the anterior side we perform the interruption suture because that is why we can quickly reconstruct it.
Ours at NYU is similar to yours. So if I usually almost always will place 2 sutures posteriorly. Same thing, 5-OPDS, RB2, and those I'll tie internally. Because I feel like if you try to get them right at like 5 and 7 o'clock, or if you do the one right at 6 o'clock, it's very difficult posteriorly to. It doesn't never really sits right. And so I agree. I think as far as tying it with the least amount of tension, I find that the internal ones do the best.
Yes.
And then all my anterior stitches are all external.
Yeah, makes sense. Oh, do you know this method? They retract the needle, but not pulled too much. They just place the needle just outside the jejunum. I think this method is very unique and very convenient to make sure that the position of the needles. With this method, we will seldomly lose the needles, even if we use this kind of the multiple interrupted sutures. And I was very impressed by watching this method in a first visit to TVGH 7 years ago. And of course, I implemented this method to my practice, and I named it as a needle anchor method. And I wrote a paper using this name, thanks to the TVGH groups. And of course, I made some acknowledgement of their groups for my gratitude.
I find more issues with the other end of the sutures, particularly because I do the same thing. I tie 2 on the back, and then I start cephalad and kind of run every place the stitches anteriorly from starting that way. And the tails on the pancreas side can kind of get in the way. So this is something that one of my colleagues taught me, is that you take a very small bite of the pancreatic parenchyma, and just a very, very thin bite, and then you take your actual true PJ stitch, and what it does is it kind of tampers down the tail so that not all the tails are sticking in the air. Because to your point, I mean, if you can sometimes grab the wrong one, whatever it may be. And so by taking just a little bit of the parenchyma, not deep, just a little bit of the top, then that kind of tampers down the tail that would otherwise be kind of flipping in the air. And so I find that organizes my sutures a little easier.
Okay. So in your practice, you use this direction from pancreas to jejunum, or reverse?
I do it this way. I do it this way. Sometimes for the ones that are the most on the inferior aspect, sometimes it can be easier to go from, because the way the stitch goes, it's really, you almost have to do it backhand in a way. So some of those stitches, I find it easier to go from the jejunal side and then into the duct. Very rarely, if I have a really small pancreas duct, I'll go the jejunal side first and then go into the pancreas side. So that way I know for sure I'm actually in the duct when I do it, but yeah.
Professor Shi, how do you use this kind of additional tube to guarantee the lumen? Yes. Okay. It's a very good idea.
As you mentioned, to guarantee the lumen. And also make sure not catch the opposite side of the lumen.
You mean the posterior wall?
Yes,
Yeah.
yes, yes.
Professor Wang, do you prefer to take as much as possible the parenchyma, pancreas parenchyma? You make a very big stitch over, duct to mucosa.
For this case, yes, because I feel it's very easy to break the tear the pancreatic tissue when I'm going to tie them down.
Okay.
So that's why I want to take a fairly big bite. Otherwise, I think in our experience, sometimes when we are trying to secure this knot, that you can get a tear.
Okay.
Yeah.
So this is a kind of a special setting for this specific patient.
Yeah, for this case.
Okay.
Because very fragile fatty pancreas, you can, if you take too thin of the bite, I think when you tighten the knot, you can see tearing of the pancreas parenchyma. That's what I don't want to see.
There's a question about, is there any other tips for avoiding bleeding during the bronchi, especially penetrating suture pancreas? Also, tip for control the bleeding.
Actually, there is
all the commentators, we're already discussing the tips. I think many of the commentators were giving advices, and I think it's quite important when you try to place the penetrating pancreas stitch. Actually, my camera is always trying to check whether my needle, the point of coming out, whether there's any suspected vessels. And most importantly are the two edges. The two edge side, you can easily get some bleeding.
Yeah.
Especially my first one, when I was making the penetrating suture, I don't know if you guys see it. It was actually bleeding, so I took out and compressed. So if you see a bleeding and yeah, if you see a bleeding and the bleeding is pulsatile, then you have to give up. You have to give up that penetrating choice. And then what we do is we pull out the entire needle. The entire tract should be abandoned, and then we use compression first. And that's the advantage of robot, because once I use the gauze to compress, and I just move my head out of the camera, and it stays there. You can wait a little bit, and then you can come back and check whether they're still bleeding. And most of the time, it can stop. And then you have to, the tricky part is you have to start picking another penetrating region. And if possible, sometimes it's better that you pick behind it, so that maybe we can have more compression on the previous penetrating bleeding site. Yeah. But if it's not possible, first of all, if you feel can't, after compression and you check and it's still bleeding, then one of the commentators was saying that you can sometimes go to the posterior side and sutures. Professor Inoue said that, right?
Yeah. Yes.
Sutures. Sometimes we do that too. Yeah. We'll go and check the orifice of the bleeder, and then anterior side, I think most of the time of the compression, it's okay. Posterior side, you can find the bleeder, and then maybe using a 5.0 or 6.0 proline, then you try to fix it. Yeah, suture. Yeah.
Professor Shi, still there? Yeah. I ask you, when you are dealing with a very thin wall of the P duct, posterior wall, very thin, this issue, you got concern or trouble you? Very thin posterior wall or P duct?
No, I don't think so. We just do the same way. You mean the P duct is located very posterior.
Very near to the posterior wall.
We just catch it.
Okay.
We don't change any policy.
Okay.
From this anastomist, I found Dr. Wang, he performed the edge suture, 3 anterior and posterior 5. How many suture is suitable?
Okay, Dr. Professor Shen's question is for me or for everybody?
Both.
For this case, I'll answer first. Because I use the 8 French, so I think today the pancreatic is not so, excuse me, can I have some attraction? Yeah. The pancreatic is not so small. It's actually okay, but the wall is very thin and the pancreas is very fragile. So if I use the 8 French, I sometimes consider maybe 8. Maybe 6 for this case would be enough, but I think that the duct is too thin, so I actually want to cover the whole thing. So we do a pair watch starting from 6 o'clock and work my way through 12. So this is like 1.5 o'clock region, 12, and yeah, 10.5 o'clock region. So I want to make sure it's evenly spaced out. Yeah. So usually for a thin duct, maybe 6 to 8 stitches is enough.
Likewise, I use 6 stitches for 2 millimeter or less, and more than 3 or more, we use the 8 stitches or continuous for posterior and interrupted 5 for anterior. What is your opinion? 6 is in average your standard for small duct? 6, okay. that they are applying the anterior suture and the tying using the slip knot technique. Oh, it's very smooth. Do you use the slip knot technique for time? You use it. How about you, Professor Nagakawa?
Yeah.
You don't use. Okay. Professor Wang, do you grasp the small gauze with your left hand not to injure the jejunal wall, right?
Yes, I like to use the small gauze to help
It's very
manipulation.
helpful.
Yeah. And because I really want to check my final stitch, and so I can make an even horizontal matrix suture of the rest of the stitch. So sometimes I like to check the ball often, and I'm worried about maybe injuring the ball. That's why I like to use the small gauze, call it peanut, to help.
Okay.
Yes. And I want to emphasize I think the advantage of this slip knot really, especially if you see the final one, the tension is much more. So if we use slip knot, we can completely control how tight we want to use. Well, we want to secure this final embedment of the pancreas stump.
I also follow your method. Yeah.
Thank you.
There's one question about the website. The doctor worry about the migration of PJ stent. So he asked about, is there any method or needed to stay suture for pancreatic stent? Stay suture.
I know the TBGH group doesn't fix the lost stent, right? You don't fix. Actually, I fix the lost stent to the posterior of the anastomosis using the 6 or fiber absorbable sutures. How about you?
Yeah, I will
You fix
it.
Fix. Okay. Most of us fix.
Oh, actually, I had two cases. Actually, that is after the surgery. Actually, the pancreatitis occurred because of the stent of the surface stent of the stent that hit the jejunal mucosa of the jejunum.
Okay.
And then the stent was obstructed. And then the acute pancreatitis occurred after the surgery. So that's why actually the RO is fixed and never moved the pancreas after the resection.
Okay. Dr. Wang, have you received the result of a frozen section of each stump?
Mike. Yeah. I'm sorry, I forgot to actually, because you guys were discussing, and then I forgot to. It came out just not even after. I think after we were trying to bring up the jejunum. So it's pancreatic cancer, and the margin of the pancreas and the bile ducts are free.
Okay, congratulations.
Yeah, pancreatic cancer. Yeah, thank you.
Final question is, he asked the email of the institute head. He want to learn the surgery from the institute. I think all the attendees can send you an email.
Email?
Because this doctor want to learn surgery from the institute, perform the operation.
Yeah, of course. I can share.
Yeah, maybe
but let me know his name.
I think all the attendees, especially Norway, John, okay, send you an email.
Yeah. I can share. Yeah.
I want to learn the surgery from the institute.
You can send doctor's email.
Yeah.
Want to know
how to answer.
Before HG anastomosis, you place the tip of drains nearly behind the PG anastomosis at this stage. It's behind SMA, right?
Open the mic, please. Microphone. Okay, so this is the part where we want to make sure our drain is in the place that we worry about. So this is the drain 2. So usually we come from behind the pancreaticoduodenectomy and then wrap it around. And we try to insert it around the SMV and SMA, just next to it.
Okay.
But you have to be, when you do that, of course you have to really be careful. So I always emphasize on you have to see before you can do anything. So if I can't see anything, then I don't want to try. So I always make sure my exposure is okay.
Yeah.
And I can
really
see
agree
well.
with you.
Yeah.
In
And
robotic
then,
environment, we should not perform the blind maneuver.
yes,
Yeah.
yeah, because you don't have any feelings.
Yeah, yeah.
So visual, direct vision is very important. You have to see what you are doing. And then this is the number one we are going to place. So this one comes above the PJ anastomosis, and again we wrap it around. And it's not difficult. You just follow this strand next to it. It really comes out.
Dr. Wang,
yeah.
did you have any trouble when you are trying to
removing the drain?
To pour out
No.
your drainage tube?
No, we don't have trouble pulling out the drains.
How about the drain exchange? Do you have
yes.
any experience?
If we want to exchange drains, if there's a leak, we only consider starting to exchange the drain unless I'm sorry, I have to find my other. Yeah. So in case of maybe POPF and it's the drains are being placed for a pretty long period of time, usually more than 2 weeks, we will consider starting to exchange the drain if it's necessary. But most of the time, you actually don't need you don't really need to exchange the drain because you can see we cover it very well around the. Only until maybe you see that the leakage is diminishing or minimizing, and we are trying to sequentially remove the drain.
Okay.
Then sometimes because this JP drain is quite long, then so when you sequentially remove it, then part of the drain will be exposed. Then you will have like a leakage on the site. And sometimes it's not easy for the patient to take care. Then we consider exchange the drain.
Okay.
And that usually is after about 2 weeks period of time. And we exchange it. The track is pretty much still there.
Okay.
Yeah, we don't expect putting the drain entirely in a circle fashion, but usually the straight part is still there. So when we design the drain, it should be like dependent and very straight, so that it won't be difficult for us to exchange the drain after
so you
at least 2 to 3 weeks.
replace with the shorter one.
Yes, we usually replace it with 16 French nasogastric tube or 18 French, because this is the 18 French JP drain. Gauss, please. Yeah. So number one goes around the PJ, above the PJ, and then it comes to the Morrison pouch, which is just below the choledochojejunal. So this part, this strain can also check whether there's any bile leakage.
Yeah.
Okay. 好，准备。
So, Professor Wang, in this diameter case, you prefer the continuous or interrupted? I think it's more than 1 centimeter.
Yeah. Yeah, thank you for your question. So we were just discussing, because for this case, the duct size is not small. So of course we can consider continue suture with our usual method of double needle. But today the tissue is very fragile and a lot of bleeding. So I'm thinking about interrupt suture. Is Professor Shi still on the? on the scene?
Yeah.
Professor Shi.
Any comments?
What? Yeah.
Usually
I follow.
We have two
Follow
types.
his suggestion.
Please concentrate for your operation. I can
Yeah,
answer
but
that
what's your
question.
suggestion? You want to do continue or interrupt?
I think you can do the continuous.
Okay, then we can change.
Because the wall is not so thin. And the lumen is dilated enough for continuous.
没有啊，这不是，它不是啦。那如果要这样，就设计
18加12。
Thanks to your boss' advice, now you change your mind.
I think a continuous is okay.
Okay,
for the thin non-dilated bile duct, we usually prefer the interrupter. But for the dilated and the thick bile duct wall, continuous is faster. No, we don't use stent. Usually not.
So, Dr. Wang, for this diameter, how long is your sutures?
Open the mic, please. 打开。Oh,
yeah,
okay.
Yeah. What is the length of a continuous suture?
I just ordered 14.
40
sorry.
centimeter.
Did I put 16, right? 16 centimeter
Okay.
to 10. Okay. Yeah, always our shorter arm is 10, right? My shorter arm is 12, sorry. Shorter arm is always 12, and the longer arm depends on the diameter. But today, I think, today I think we can use just 16 centimeter.
You mean
So
the
16
handmade double-tailed?
Yeah.
Okay, double-tailed.
We use a homemade double needle. And for the short one, it is always 12. And for this bile duct, I think 16 is okay. For the large, more dilated one, maybe 18 or 20.
And the longer tail is for posterior wall, right? Okay.
to use the barbed suture for posterior wall suture. Did you have any experience? Barbed. Is there anyone who used the barbed suture? No one. Okay.
I prefer the barbed one suture in the posterior layer from the right side to the left side, and then make interrupted anterior layer sutures is a very provide the good the view to make accurate anastomosis and then shorten the time. So the usually takes 10 or 15 minutes to do the hepaticoduodenectomy.
And after HA anastomosis, I cross the whole of mesocolon, I mean the pathway, using some stitches. I learned this technique from Professor Nagakawa. And what is your opinion about crossing the pathway? I know you applied the crossing.
We
crossing
must
sutures.
close the hole to prevent the internal hernia. That is
Yes,
very
exactly.
important to do the kind of procedure.
Professor Yoon, you don't agree? You don't close, okay? I have a very bitter experience of my very second case of RPD. We suffered a sudden internal hernia on the 10th postoperative day. Up to nine postoperative day, the patient was very fine, but just on the afternoon of the postoperative day 10, she suffered very severe abdominal pain, and we checked the CT scan, and the afferent limb was extended, and we took her to OR for emergency operation, but we need the re-anastomosis of the bile duct. It was disrupted already. So after that, I followed Professor Nagakawa's the principle, and we placed the 3 stitches at the mesocolonic holes.
Experience is very important.
Yeah.
I'm
so experience-based surgeon.
Any experience about that. If I experience once, I will close effect.
You have never?
Not yet.
Wow.
Closing the hole is a very simple procedure, but without preventing the internal hernia. So if you have the many experience, you have the many chance to have that kind of problem. I have the 2 emergency operation like that. So that is very simple, but very important to prevent that kind of event.
And I noticed, and I was somewhat surprised that you applied a closing suture before anastomosis. Just you pass through the jejunal limb and you immediately close the hole.
Because the optimal limb, the length is important.
Yeah.
If you make too large, too the long, the segment is pulled to the above side of the mesocolon, it makes some kinking of the jejunal side, make some obstruction event. So the optimal the length of the apparent loop is very important. So the fixed length of the A loop, I fixation the first.
Just after you confirm the optimal length.
That's right.
Okay.
Yeah.
Okay, makes sense. I think assistant interaction is very, very sophisticated. It's based on the experience of more than 900 cases. Professor Xi, can I ask you a very critical questions? Yeah, do you have any plan to reduce the number of assistants in your robot whipples? Usually you use the 2 assistants. Yeah, but do you have any idea to reduce to 1 assistant?
If the bedside surgeon is competent, 1 is okay. Like the Dr. Julia, Dr. Senior, they can do that. But for me, I'm too old. I have to need the other one. But if the bedside surgeon is resident, we need 2. We need 2.
So using the longer tails, you sutures from the 3 o'clock and 4 posterior wall and up to 10 o'clock or something?
You will see, we will use, usually we fix the longer one at that point. And then start today, I think Professor Wang do not want to fix the longer one. And we start from the other side, from 3 o'clock.
Okay, can everybody hear me?
We can hear you. And today
Okay.
you do not fix the longer one.
Because I want to save time. Now I don't like to. Please go above. Now I don't do preset stitch anymore. I think with the 4th arm, it's you can do a good traction, so I don't do a preset anymore.
I think you can finish this one within 20 minutes. Now you just take 30 minutes for the bioduct anastomosis.
There's a question that asks about what is the size of suture material or hepatical jejunostomy and the size of needle.
This is
usually 4.
4 or 4 or PDS.
4-0 PDS.
Yeah, 4 or PDS. And I think to answer Professor Inoue's question about reducing the patient, I think, if we are shortage of manpower, then of course we are able to do that with just 1 assistant as well. Especially when it comes to the reconstruction, I think usually we can have just 1 assistant.
Okay.
But since we are a teaching hospital, and so most of the time it's for their training. Like today, you saw a lot of applying of the hemolock. Also changing instrument. This is for their training. Yeah. So right now we still use 2 assistants, but sometimes I do tell them that they can take rests after the resection part is over, and then we can just have 1 assistant for reconstruction, actually. Yes.
Okay.
Yeah.
Is there any chance for your fellows or young trainees to serve as a consult surgeon in the Whipple procedure?
Yeah, fellow.
Okay, fellow.
Mostly, yeah, we allowed the fellow to try to do a breakdown of these procedures. The robot procedures are broken down by me if I want to let them try some of the procedures. Because if you let them do the entire procedure, it's very challenging.
Yeah.
And I think it's both challenging for them and also for me mentally.
Yeah, yeah.
And so
You can divide the sections.
Yeah, I divide the section. Usually they can start by taking out the stomach, like taking out the gastropupillary artery, the right gastric artery. Yeah. Taking out the stomach is the first step. And then maybe after I confirm the gastrocolic trunk, especially the colic vein is being secure, then I think cochlear maneuver is the next step they can try, which is, yeah, they can try to do cochlear maneuver. So we break the procedures down, and anything to do the vessels or anastomosis of the pancreas should be the last stage.
Okay.
Yeah. So Mandy actually is about to finishing her training, and she has, yeah, think Songyan, yeah, she has almost, I think almost, right, completed all parts, but it's in broken stages, not in one patient. Yeah.
But still, I want to congratulate Mandy. Yeah.
I think it is really important I mean, can't overstress how phenomenal the assistant, obviously the surgeon, Dr. Wang, is phenomenal, but the assistants here, this is not a common thing, how good your assistant is here, at least certainly not in the United States. And so,
Thank you.
I think it's really important.
So that's why I think it's important that I want to train my assistant to do the same thing. Today, of course, we have attendings, but now in the usual HIPAA operation, there's usually chief resident or sometimes even rotating residents on the scene. Yeah, sure can.
Yeah, I think particularly for individuals who are interested that don't do this procedure yet and are interested in doing this procedure, one of the key critical steps is to start, I do think, to start with an attending at the bedside and or someone who's incredibly experienced with this, just because, as we take on these complex cases, it's a big mental load. And so I think if you can have another surgeon available to do that, then that's wonderful. Some centers don't have that. And so this is where we've kind of talked about, telepresence and a couple of other ways to kind of get around that. But I think figuring out your approach from a standpoint of who's going to be at the bedside, what is that bedside person going to do, I think is really critical in trying to get a successful program off the ground. So I think it's really, really important. I do think it's a key part too, as far as trainees, because if you can tell pretty quickly if the bedside assist knows what's going on, if they're anticipating the movements, as opposed to you just having to tell them what to do. One of the things that is challenging for us in the United States is most of the bedside assists are NPs, and certainly some of them, they're just there for the, they don't look at the case, they don't really kind of understand too much, and so you literally have to tell them, move here, do this, do that, and there's no anticipation. I'm very fortunate, we're very fortunate that we have a very consistent PA and NP that do these cases, and both of them are phenomenal and do anticipate the movements, and that movement, that aspect alone saves a lot of time in the case, because these cases obviously can take some time, and so I think anytime you can save time in the case without sacrificing the quality is key, and anticipating steps. So for example, when sutures are being brought in and brought out, that's a key part of the case, where if somebody brings in the suture while they're bringing out a suture, that can be very helpful and speed things up, and it doesn't at all sacrifice any of the quality of the case. So I think just parts of that in terms of, well, how can we speed up the case without sacrificing the quality, then I think are really, really key. Like, you would never want to speed up the SMA dissection, right? So I mean, there's plenty of other cases. This case is so long and so complex that there's multiple areas that you can speed up without sacrificing at all the quality of the case.
I have a question to you. So if the circulating resident want to join your operation, So how do you decide whether to he or she join the operation? And in spite of the no experience of the robotic PD, how do you decide?
For the trainee or for, yeah, right. So I think some of it is, I just actually asked them to talk about the case, and you can tell pretty quickly if somebody has a good understanding of the case, if they can talk you through it. So I think that's kind of the first thing in terms of, what did you see on the scan? What are your kind of thoughts and approaches? Because sometimes they'll respond and be like, well, I don't know. Clearly they would have, no ability to do any part of the case in that sense. So I think the preparation is important. I think if they put a lot of time and effort in terms of preparing the case, that to me shows that, one, they've taken a lot of initiative in terms of wanting to learn, and then two, they also understand certain aspects of the case. You can tell if they can talk through it. But and then as far as their experience goes, I think some of it just depends on if I've operated with them before, what cases have they done, and so on and so forth. So I think all those things are important. But as you mentioned earlier, both people have mentioned that, breaking the case down into steps is really, really critical. And then whether it's letting them do the whole part of a single step or whether it's doing a lot of parts of different steps. So I think those are kind of two different approaches. That one of my co-attendings will let the resident do the first 5 minutes of a couple different portions of the case, and then whether they're doing well or not, he just moves along. And then others, we'll let them do a whole part of the case. And so I think both approaches are very, very reasonable.
Now you completed the PJ, HJ, and you're now confirming the no bioleakage, right? And after this, you convert to this, small incision anastomosis.
What happened? Okay, excuse me. So, actually, I missed your question. Can you say again? Because there's some problem with my air seal.
Oh, yeah, no problem. Yeah, I just congratulated you on your
thank
great
you.
performance. Yeah, and then now
Yeah.
I was asking that from now you will convert to the small incision.
Yeah.
Yeah,
After checking for any bioleakage, and we'll go and count the distal part of the jejunum that's gonna be attached to the stomach, so we can do a pull off for extracorporeal suture.
Yeah.
Yes. So just in a minute we'll do that. I just need to confirm my anastomosis is okay.
In a couple of minutes, I think a live demonstration will be closed. Yeah. Anyway, I really thank you, the Professor Wang, for this great performance, and we really enjoyed your procedure, and we really realized that your group is one of the most sophisticated pancreatic surgery groups in the world. I really congratulate. Thank you so much.
Thank you.
This will be a stage suture to extract the both stumps. Stops. It was cut. Docked. Professor Chen, could you give us the closing remark of this session?
Okay, since everybody joined the discussion, Professor Professor Wang, thank you. You do a wonderful operation, and everybody join this your operation. Any question for Professor Wang? If there's no question, we will close in the this section.
Thank you.
太好了。
Thank you.
May we ask all of you to have a picture with the surgeon inside the OR on the screen. So we have to face back. Face back. 美心，我们现在要照相哦，你请他们来站在你旁边，然后里面外面照一张。
好，我们要照到病人还是不要照到病人？
我想可能不需要吧。
好。
对，恭喜哦，你今天还很好啊。
哦，谢谢老师。
好啊，请他们都过来。
好好，有他们正在准备。
请问他里面看得到我们外面吗？可以哦。可以。所以你看得到我们外面的人吗？
有，我们现在有看到你们。
Okay. We have a picture inside and
我
outside.
的nurse，站过来了。谢谢大家，谢谢。今天真的辛苦。再往后好。那我是站，好，等一下，在这。我站后面。对，这样。雅茹呢？等下，赶快来哦，来。I also need to thank everybody. 来，谢谢。看那边，不要看。好。看上面还是等上面？好。谢谢大家。好。太恐怖了。好了吗？还在等。
Okay, look at here.
还蛮好笑。
笑容。
我是讲话听得到。好。
刚哦。
好。
来，1、2、3。好，可以，谢谢你们。
好，谢谢。